Hello, welcome to all for Retelecast of Most Demanded Periprosthetic Joint Infection Webinar by Team GOA.
Hello,
So, thank
welcome
you.
to all for
High-end computer can do it.
Yeah, what a relief after talking about, he's listening about Corona, a beautiful sea surfing land, huh? Rajesh?
I think all miss it now.
Rajesh bhai, what you need to have, you should be in Bermuda now at this, in this.
I know.
Anyway, anybody can see only the upper part of in the screen.
Yeah, I know. They can't see my Bermuda shots.
Yeah.
Because how is the situation in Germany for
situation in Germany now? It's getting better. So the big wave of the first hit of COVID-19 is now over. Lockdown was until last week. So this week we are turning back to a normality, step by step, of course. And in all over Germany, we have to wear a mask, especially in public traffic transportation, and also in shopping areas. In all hospitals, we are wearing masks, and we are getting back to elective surgery step by step with patients who don't need intensive care unit background, and of course in acute surgery we were working through the lockdown, and now we get back to the elective surgery step by step.
So you have a mortality going
Okay,
down?
sir, we are now on air, and delegates are waiting. And let me share you that 3,420 people have already clicked the link already, or gradually they are increasing. So we are very much thankful to all the faculty and Dr. Dipak Bhai for accepting the invitation of Gujarat Orthopedic Association, all the faculty and the delegates. And for the delegates, just I want to show the screen where you can have a recordings here, and you can see previous webinars recording here. And as you go down, just click this red arrow and you will get this webinar live. And whenever you want to ask the question, type your question here. It is a Slido window, and we have restricted your question to 160 characters only to have a crisp question. And just click send, it will come to me. I will pass on to moderator and the faculty, and your question will be answered. Those who cannot write or they are seeing in the mobile, they can record their audio or video, and then I will just click on the WhatsApp, and I will be giving them question to moderator, right? Let me introduce very shortly. Anyway, Dr. Dipak Bhai is going to introduce Professor Javed Parvizi. Everybody knows. Dr. Akos from Berlin, Germany. Dr. Rajesh Malhotra sir. Dr. Sachin Tapaswi. Dr. S. Vaidya. Dr. Saran Patil. Dr. Rajkumar. Dr. S. Mohanty. Our own Dr. Dipak Bhai Dave, who is going to moderate this. And Dr. Yuvraj Lakum and Dr. Karthik will be co-moderating, and I will be just linking you with the audience. So you can take over, Dipak Bhai, now. It is your screen. Just take away. Share the screen.
Yeah, share the screen.
Dipak Bhai, you can share the screen. My screen will go automatically.
So at the outset, let me thank Dr. Javed Parvizi and Dr. Akos, two very eminent figures from USA and Germany to be part of this webinar. So on behalf of Gujarat Orthopedic Association, we thank you very much for sparing their valuable time. It's a little awkward for Dr. Parvizi too early in the morning, and for Dr. Akos also. Apart from that, we have Dr. Rajesh Malhotra, who is the head of the Department of All India Institute of Medical Sciences Orthopedics in Delhi, Dr. S.V. Vaidya, the eminent surgeon from Mumbai, and Dr. Sachin Tapaswi, the Sachin Tendulkar of Pune. Fortunately, all these three have been the part of the previous international consensus meet, which was chaired by Dr. Javed Parvizi on the infection of the periprosthetic joint. We have Dr. S. Mohanty, who is the current president of the Indian Arthroplasty Association from Mumbai, Dr. N. Rajkumar from Ganga Hospital, Coimbatore, where Dr. Parvizi was one of the guests invited for IOACon last year. And we have a senior arthroplasty surgeon, Dr. Sharan Patil from Bengaluru. So we have a galaxy of Indian faculties also. And once again, I would like to introduce Dr. Javed Parvizi with all privilege and honor, who is the Director of Clinical Research at the Rothman Orthopedic Institute, Philadelphia. He's a world-renowned expert in the field of periprosthetic joint infection, joint reconstruction, and joint preservation. His other interests are in the subjects of hip pain in young adults and prevention of thromboembolic disease. More than 800 peer-reviewed scientific articles, 30 textbooks, 200 book chapters, and received more than 50 awards and honors from various societies for his surgical research and activities from across the globe. He is a co-founder of the International Consensus Group, which is a Bible and Gita for the infection of the periprosthetic joint in orthopedics on orthopedic infection. And he was the chairman of the two meetings which were held in 2013 and 2018. With great privilege and honor, I introduced Dr. Parvizi to give his talk, and which will be followed by Dr. Akos's talk, who is also a very senior arthroplasty surgeon from Germany, and is involved in the research and innovation and education. He's the chief of the orthopedic department at the Helios Hospital, Berlin. And formerly, he was attached to Endo Clinic in Hamburg. He has worked in a number of countries, UK, Denmark, Hungary, USA, and Germany. His main interest is the complex revision joint replacement surgeries of the hip and knee, with special interest in the single stage revision. With more than 100 publications and 30 peer-reviewed journals and 7 book chapters, I welcome Dr. Akos for this webinar, and I request Dr. Parvizi to start his talk and share the screen.
Thank you very much, Dipak, my great friend, and it's wonderful to be on this webinar with you all. I really, really appreciate the opportunity. And Dr. Thakkar, thank you so much for organizing it. It's wonderful to see my good friends, Dr. Vraitia, the Malhotra, all the others. And thank you for all of you who are so committed to education. And I know we're going through trying times, terrible situation, but we will prevail. And I look forward to coming to visit India, shaking each of your hands and sharing a lassi or of some drink. Very soon, hopefully. Thank you, everyone. So Dr. Thakkar asked me to give a talk about diagnosis and maybe an update. First of all, on the disclosure, as you know, I have been working on the next generation sequencing or molecular techniques. So I am conflicted because I work with a company that has produced that test on a commercial basis, the only company that has done so far and is available for commercial use is called MicroGen-Dx. So I'm somewhat conflicted when I talk about the next generation sequencing. We all know that infection is obviously a terrible problem, and situations like this arises in the operating room not infrequently, and it carries high morbidity. It puts these patients through terrible times. It leads to amputations, and more importantly, infection kills. As you may remember, we published a paper showing that the 5-year survivorship of periprosthetic joint infection is very similar to other cancers, and it's 4 times higher than age and comorbidity matched group of patients who are undergoing aseptic revision. So it's not just their age or comorbidity, it's really the underlying diagnosis that unfortunately puts these patients at risk. And that's quite honestly not a surprise, because infection is just like cancer. The bacteria and the pathogens communicate through intramolecular signaling system that's very similar to cancers. So this is one of the original graphs we published. And unfortunately, it appears that infection can kill. Diagnosis is really a challenge, and this has been so for the past few decades. And incidence and prevalence of infection is a little higher than what we all believe. And as you can all see, and even in India, where I was visiting last year, we had this debate. It looks like the number of infections may be going up. The reason is because we're really paying more attention. In the old days, when we would have seen a patient, not looked for infection, and we would have considered it aseptic, but now we're maybe paying a little bit more attention. And one study from our institution shows that about 12% of so-called aseptic cases were actually infection, that they were either not investigated properly or the modalities we have for investigation is not sensitive enough to pick it up. One of the things that we have to be careful about is reading registry papers to really make sense of infection. Registry data is unfortunately not great because it doesn't have detailed granular data to be able to give us really conclusive information related to infections. And here are some of those that have declared that that registry data may not be great. So unfortunately, including registry data that Dr. Gary Hooper wrote from New Zealand related to the use of laminar flow or multiple other things, may not entirely be reliable at this point. Infection is definitely a very hot subject. There has been an increase in the number of publications in recent years, and that continues to increase. And fortunately, educational venues like this one allows us all to exchange ideas, allows us to think about ways to improve the care for these patients. But diagnosis still remains challenging because there is no gold standard. And if you really want my opinion, I can tell you that there will not be a gold standard. There will not be a single test that will diagnose implant-related infections in the future. This is just one of those realities in medicine that we have to admit. And there's many of them in medicine that just don't have a single test. How do you diagnose ankylosing spondylitis? How do you diagnose lupus? How do you diagnose depression? How do you diagnose rheumatoid arthritis? Many of these conditions in medicine have criteria. They don't have just one, because one test to diagnose that particular condition doesn't exist. And PJI is one of them. I hope I will be wrong, but it will not be soon. If that test, a single test, is going to come, it's going to be way down in the future. And no uniform criteria for infection existed up until 2011, when musculoskeletal infection group, we got together and came up with a criteria, which I will discuss. And because of that, the accuracy of all these diagnostic tests, when you combine them, was around 80%, not 100. And there were, unfortunately, as many definitions for infection as there were publications and investigators. Look at this table. I put this table together. In 2006, I defined infection as one that has a positive culture, there is purulence or sinus tract, when serology is positive. And then in 2008, I changed that to a different definition. So you can see, even for a single investigator, there were like different definitions at different time points. That's why it was so difficult to diagnose infection, and that's why there was not a single criteria. But we will talk about the criteria. So infection is difficult to diagnose because we all know about biofilm, but we also have come to realize in recent years that bacteria can internalize into the cell, hide inside the cytoplasm, and these round bodies that you see here, the large dark body is the nucleus of the osteoblast, and the small round bodies that we're looking at over here, all of these are Staph aureus. And this is a phenomenon that's now becoming more and more clear, that the organism hides inside the cell, remains inactive for a long period of time, and when the time comes, they get reactivated. So this explains why you have an ACL that got infected 15 years ago and now you need a total knee replacement. You can get infected by exactly the same organism. That organism was hiding inside the cytoplasm. Now, we know that eukaryotic cells could do this. Virus, for example, chickenpox and shingles. While the child contracts chickenpox as a child and then can get shingles as an adult, that virus is exactly the same one. It was in the cytoplasm of the neurons that then under adverse physiological circumstances starts to proliferate and result in shingles. And interestingly, this phenomenon has been investigated. This is a very interesting study that was done in Morgantown, Virginia. These investigators infected the osteoblasts with the Staph aureus and then inoculated them into an open rat fracture. So at the top here, osteoblasts are together with the Staph aureus, were left there for 2 hours. Then they wash out all the extra Staph aureus and also administer gentamicin to the osteoblast. So what they're left with is just osteoblasts and no Staph aureus. Then they transfer the osteoblasts to the rat fracture model over here, and you can guess what happened. All fractures got infected. How? The Staph aureus externalized from osteoblast and then resulted in the infection. This slide is a work of one of my great friends, Eddie Schwartz. It's worth explaining to you what's going on here. If you look at the slide at the bottom, these arrows, the yellow arrows, are showing the Staph aureus. This is an electron microscopy of the bone in a mouse. This is a mouse model where they infected the mouse with the Staph aureus. And what's happening is as the Staph aureus is proliferating, marching along the canal and killing these pink purple looking cells are macrophages and neutrophils. If you look, these are multinucleated, and in this region, and I hope you can see the arrow, in this region where the yellow bodies are invading the neutrophil. In fact, one of the Staph aureus has managed to go inside the osteoblast, into the neutrophil. Neutrophil is dead, no sign of the nucleus anymore. And in a few minutes, the Staph aureus will continue to kill the rest of these immune cells and invade the entire intra-articular canaliculi. At the top, the sort of picture B here, that's an osteoblast in blue. And again, the round body inside is Staph aureus, another example of how internalization can happen. So that explains why when you get osteomyelitis, doesn't matter how hard you try, how much bacteria, antibiotics you give, we cannot eliminate the bacteria. That's the story. The story is they are inside the canaliculi. And then biofilm, which I'm not going to bore you with the concept of biofilm. Every one of you is very, very familiar with biofilm. So what about other problems? Well, culture, unfortunately, in implant-related infections is not very good. It is still very valuable for us to do it. But culture coming back as negative should not give you the false impression that there is no infection. Culture can be negative in up to 48% of some of these infections, as has been described by numerous investigators that I've listed on this slide. So just because culture came back negative shouldn't give you false assurance that the patient has no infection. The other issue is that these tests we use for diagnosis of infection, none of them were developed specifically for diagnosis of PJI, and their thresholds were determined over a period of time, and that has undergone huge changes. So let's talk about culture, for example. You have to take the culture from representative areas. You have to take at least 3, preferably 5 samples. When you're taking the culture, it has to be a clean instrument. to avoid contamination. Don't take the culture and then put it on the hand of your assistant, and then he or she then picks it up with their fingers and then put it inside the bottle, and the bottle sits on the side for hours before it goes to the lab. No, clean instrument, representative area, direct transfer to the bottle. And as soon as you stop taking culture samples, those samples have to go to the lab. We have to call the lab and let them know it's coming. Synovial fluid preferably should go into the pediatric blood culture bottles for transport purposes. And then you have to know whether you're going to ask for fungi, you're going to ask for mycobacterium, atypical organisms or not. They won't know in the lab what you want them to do. You have to give them instructions before they do that. Serology. We say serology is abnormal if ESR is greater than 30 millimeter per hour, if CRP is greater than 10 milligram per liter or 1 milligram per deciliter. Well, it will not come as a surprise to you if I told you that there is a variation in the level of these tests, both based on temporal and based on demographics. So we have two papers coming out. One paper was measuring the level of ESR and CRP taken from the same bottle and sending it to 3 different labs. All different labs came up with different values. The second study was when we took those bottles at one time point and then brought the patient back 48 hours later and took the same sample and sent it to 3 different labs. Interestingly, not only the 3 different labs gave us different numbers, the value of ESR and CRP from the first sample to the second sample varied up to 30%. So we are putting so much faith and so much understanding on this ESR and CRP level. And I will tell you, ESR in the old days, and I'm old enough to know this, used to be measured manually by what's called the Westergren technique. Those ESR bottles were black top. They had a little trim on the sides. You would shake it, put it against the ruler, wait for 1 hour, and then you would read the ruler formation, and that would be ESR. Now ESR is being done automated fashion. How do we know that the automated level corresponds to the old Westergren technique? In fact, there are papers showing that they could vary by 10 to 20%. So what I'm trying to tell you is that, yes, sure, of course, ESR and CRP is useful and we should do them. But don't feel like ESR and CRP is the be-all and the end-all. There are variations and there are differences between different labs, how they are done. And then the complexity with CRP is that it has 2 units, milligram per liter and milligram per deciliter. Now, residents call me on the phone and say, CRP is 10. Well, 10 what? If it's 10 milligram per deciliter, that's 100 milligram per liter. So there are differences in the units as well, and different labs are still using different. Synovial test, yeah, I mean, if you look at the number of cells, the neutrophils, etc., in the early days when the research came out, some were talking about cells per mil, some were talking about cells per microliter. We don't know what they were talking about. Is it acute, chronic? And for those of you, my friends who were in the international consensus, you know that there was a huge debate going on at the consensus saying that 30-day cutoff between acute and chronic is artificial, is illogical, it's irrelevant. I agree with all of that. Of course, that's correct. You can be acute on 29 days, 23 hours, and 59 minutes, and then suddenly is 30 days and 1 second you're chronic. How did that happen? I agree. That division of acute versus chronic is not logical. So we have to think about other ways. And I will tell you one thing that I think would help us. But in any case, we do know that acute infections exist, and we do know that chronic infections exist. How do we decide? Well, the consensus recommendation is don't just decide based on time. Use other metrics also to determine if a patient of yours is going to be a candidate for irrigation and debridement or not. And that's not just with time. There are others. And we got that DARE calculator. It was the winner of the Hip Society Award this year at the Academy. Obviously, we were not there. But for those of you who use the ICM Philly app, now we have on the app the DARE calculator. So if you have a patient that you think has got acute infection, you can put the parameters. It will ask you, and it will give you a number about expected success rate. And then you decide whether that expected success rate is acceptable or it's not. If it's not acceptable, you should do resection arthroplasty. If it is acceptable, you can certainly attempt to do DARE. So again, 256 different criteria. Obviously, you don't have all of them, but it will ask you for all the ones that you have. And based on what you give the app, which is AI machine learning based, it will give you a number about the expected success. So if you haven't used the app, I urge you to download ICM Philly, and I'll talk about it a little later, and try out that DARE calculator. Histology, another example of how much variability there is. It's operator dependent. It depends on where you brought it from, which region of the hip or the knee this was taken, who looked at it, what they defined as neutrophils, what type of magnification they were looking at, et cetera, et cetera. So I brought out to you the issues that exists with the use of these tests currently. And C-reactive protein also doesn't have 100% sensitivity. It can miss infection in some of these. White blood cell, if you're using 3,000 cells per microliter, also doesn't have 100% sensitivity. So why do I tell you these? The reason I'm telling you this is that that's how we have come some way from where we used to be. MSIS convened the group. We met. We then used the available literature. We talked about standardization, tried to improve the definition. We got all of these, and then we disseminated this. MSIS had 2 major criteria and 2 minor criteria: sinus tract, 2 pathogens from different cultures, and then the minor criteria that you know about: elevated ESR, CRP, synovial fluid, synovial PMM percentage, histology, and a single culture. But if you read that article that we wrote, it says at the bottom in a paragraph that infection may be present even if less than 4 of these minor criteria are present. And at the time, we were thinking about P. acne or now C. acne. But we've come to realize that there are also other organisms that can fly under the radar and not be detected. One of the classical example is coag-negative Staph aureus, Crinobacterium. We have organisms such as Burkholderia cepaceae. The list of organisms that can cause implant-related infections is increasing. And just because ESR CRP was normal does not mean the patient is not infected. Academy, again, Craig Della Valle and myself were part of the group that worked on those. I think you've seen them. Very useful, still very useful. 15 recommendation, majority were strong, review of literature. Academy has produced another guidelines that just came out 2 months ago, also very useful. It gives recommendations, but I think the graphs that we produced, in my opinion, is still very useful for those of you who are residents and early on in your training. Basically, what the graph tells you is there are 3 steps in diagnosis. 1, you order serology, ESR, CRP, D-dimer, fibrinogen, whatever you want. 2, aspirate the joint. And aspiration is critical. Send the fluid to cell count, neutrophil differential, culture, a biomarker if you want. And now we're doing next generation sequencing, molecular technique. If you cannot get enough fluid or it's dry, then you should re-aspirate a few days later. If that reaspiration is still negative, that's when you start to think about things like bone scan, maybe open biopsy, etc. Bone scan, MRI, none of these are anywhere in the first few steps of diagnosis. So please don't order bone scan for everyone that you see who may or may not have infection. Just go through serology, aspiration, repeat aspiration, and then you're done. And sometimes if you're getting conflicting result from aspiration, reaspirate. And that's why the algorithm that's in that PGI DX app as part of ICM Philly, which was developed by the delegates, including yourselves, it sort of takes you through stepwise. It'll tell you, have you done this? Have you done this? And then do this, and then give that result to me. So it is stepwise based on academy guidelines that we had produced and put in that graph that I just showed you. Academy tells you, and I believe this, and I really, really think this is very important, you should order ESR and CRP for all patients undergoing revision arthroplasty, and that's regardless of the cause of their failure. Here is an 82-year-old lady who was 12 years out from a hemiarthroplasty. She's got a periprosthetic fracture. Very tempting to go in, start to revise this, do mega procedure, not to do ESR, TRP, not to take cultures, and then this patient gets infected. And this patient was in fact infected. So what you have to do is you have to do the ESR and CRP. You have all those values, and then if one of the cultures grows a staph epidermidis, then you will know whether to treat that one or not. You cannot just based on one single culture make a decision. But again, remember ESR and CRP may be normal in PGI cases. Aspiration of the joint is very, very important. If you're going to aspirate, do so 2 weeks after the last dose of antibiotics. Don't give an antibiotic to a patient unless you have confirmed or refuted the diagnosis of infection. This is particularly true for our community practitioners and other doctors other than orthopedic surgeons who do this in the best intentions for the patient, but then they really interfere with the diagnosis of the infection. So they see the patient on Friday, start the patient on antibiotics, and on Monday you see the patient in your office, and by then patient has already had 2 or 3 days of antibiotics. Not only antibiotics interferes with isolation of the organism, antibiotic also influences the level of cell count, neutrophil differential, and even ESR and CRP. If you start treating somebody with antibiotics, their inflammatory markers comes down. So then it just interferes with everything that you were going to be doing to decide whether the patient did or did not have infection. We've talked about the threshold for acute and chronic being different. I don't think you need to remember these numbers anymore because the app itself remembers them and works on those, but there is a difference. So if you have somebody who's a week out from knee replacement, you aspirate their joint, you send it for cell count. If their cell count comes back as 6,000, that's still normal. 10,000 is when you start to worry about it. And CRP coming back at 60, that's also normal. So something here, again, I'm not saying 30 days is the cutoff, but whatever it is in your mind, acute and chronic can have different thresholds, which we know about. As I said earlier, please don't order bone scans. They are not very useful. Very, very rare circumstance, you need to order bone scan. And you order bone scan, it's hot, patient is not infected, patient starts to get worried, they get fixated on that result. If it's cold, it doesn't rule out infection. So you still know wiser after ordering bone scan than you did before. Meta-analysis shows it's not very good. Molecular markers, yeah, I mean, it's all over medicine, you know, pregnancy, in myocardial infarction, PSA for prostate cancer, ovarian markers, everything now you look, there's biomarker. And I think biomarkers are very, very useful. I talked about leukocyte esterase. This is a urine dipstick. When I have visitors, they see me do this and they're so amazed on how easy and simple this is to do. It's everywhere. This chem strip is, you can buy it from Roche or Merck for $20. It has 50 sticks in it. Just have it live in your office. If you take the sample and the sample is not bloody, put 1 drop on that purple thing right here on this marker. It will tell you over here which one is leukocyte esterase. Look at it for 1 minute. If it's deep purple, 100% chance that patient is infected. 100%. It's a very good rule out, not very good rule in. But if it's blood stained, unfortunately, you cannot read it. Alpha defensing, you all know about, and of course, I was conflicted. I was part of the group that developed this. It's now available. It's not 100%, but it has very good sensitivity and specificity. Not everybody is able to do it. It's not available in every country. The one that we use in the United States is the one that we send to the lab for us to do it in the lab. It is not the lateral flow test that's made available recently. So this data that I am showing you here, this does not relate to the lateral flow test. This is the test that was sent to the lab. Lateral flow test has been shown to have different sensitivity and specificity based on European literature. It's a little finicky. You have to mix it, filter it, then drop it. You can't just drop the synovial fluid onto the lateral flow and then read it. There's 2 or 3 processing steps. And you know, based on this thing, alpha defensin and leukocyte esterase were pretty much the same. So I personally do a lot of leukocyte esterase because it's easy and easily available for me. And there's been multiple others. So gold standard, no, there isn't one. So because of the lack of gold standard in 2018, we decided to do an evidence-based, validated, multi-institutional definition. We use pretest probability, stepwise approach. And then basically what came out of this is a few things. First of all, is that not all of those minor criteria are the same. ESR is not the same as elevated neutrophil and synovial fluid. They carry different diagnostic weight or diagnostic odds ratio. So because of that, now they get different numbers. I know you're going to say, how am I going to remember these numbers? You don't have to. You don't have to remember these numbers. But for example, alpha defensin has a diagnostic weight of 3. Synovial white blood cell is also 3. So what this means is that if synovial white blood cell is elevated and alpha defensin is also elevated, you still get a 3. So you either have the alpha defensin or you don't. And you can make this diagnosis preoperatively. If the score is greater than 6, it's definitely infected. If score is less than 3, it's definitely not infected. Between 3 and 6, the 4-5 is inconclusive, and it will recommend you to go and do more. Histology is here, purulence is here, single culture is here. So if you look at this and where that graph is, using the new diagnostic criteria, then we looked at all our cases that were infected and aseptic. And these all patients had at least minimum of 2-year follow-up. So if they were going to fail, they would have hopefully failed. What we found is that the new diagnostic criteria isolated infection in 20% of MSIS negative cases. So it's more sensitive than MSIS in picking up infection. And some of those cases that I just told you, the so-called used to be called the slow-growing or low virulence organisms, the piacnes and the coag-negative staphs of the world, etc. So less likely to pick it, to miss it. It is that PGIDX app. This is under ICM Philly, and I'll show you. It was diagnosed, it was discussed, and then changed a little bit during the international consensus. There was quite a bit of discontent from Europe for some reason. They feel that this new diagnostic criteria will miss a lot of infection. It's actually exactly the opposite. Based on MSI's criteria, you will miss some infections, but based on the 2018, you will not. And right now, we just validated it against acute, and we're publishing that paper. There was 68% agreement with the diagnostic criteria, 28% disagreed. And again, there was, for those of you who were in the room, you realize the politics of this whole thing, how it span out. And it was in the consensus, you all know about consensus. I'm not going to bore you with it. It's been published. And most importantly, I think if you don't have this app, please download it. And now it's called ICM Philly, available both for Android as well as for Apple. And interestingly, now if you go to the face, there is the PGIDX, and there is a risk calculator for infection. So if you have a patient that's seeing you for arthritis of the knee and you're not quite sure if what their infection risk is, you can put their parameters in PGI risk calculator. It'll give you the number. Again, that's based on AI. And now we have another one that is called DARE calculator. And that's what I was talking to you about. If you have a patient with acute infection, it will tell you the expected success rate. So very useful. It's free of charge. The document is available on the app. And now we have formatted such that if you have a question, it will take you straight to that question. You don't have to search the 1,000-page document to find the question you're looking for. So if you are looking for, which antibiotic should I give prior to hip and knee replacement, you will put prophylactic antibiotic and will take you to those questions. It's much, much user-friendlier now than it used to be in the early days. We need better methods for diagnosis. Synovial fluid is not always available, especially in these spaces we cannot get enough fluid. And when we do, we don't know which one to send it for. Synovial fluid can give us false results in circumstances where there's metal-on-metal failure, adverse local tissue reaction. So we need a better marker, and I think PJI markers should be based on serum. We've been doing some work that was funded by OREF. We had some candidates we have looked at, and the good news is that I think we're close. There's 2 or 3 serum markers that I really, really have a lot of faith in, and I believe it will change the picture. So on this side is all the biomarkers in the serum. We're not talking about synovial fluid, in the serum, that we feel has promise, and hopefully we will come up with one of them. Then finally, and I hope I'm not going over my time, finally, pathogen isolation is very difficult. Culture negative cases do happen. This was one of the questions that was discussed during the consensus. And the recommendation was that the incidence of culture negative periprosthetic joint infection can be all the way up to 42%. So diagnostic protocols should be available, longer incubation of the culture samples, sonication of the implants, use of DTT, which Lorenzo Diego and Carlo Romano from Italy have described, PCR, and maybe next generation sequencing. And there was pretty high agreement, 91%. We have been using next generation sequencing. Culture negative is very psychologically disturbing for the patient. You're telling them you're going to put them through 2 operations, but you don't know what the organism is. That just doesn't fly in 21st century. The technique we're using is very old. Technique of culture is the one described by Koch-Bass in 1886. Things have changed. We need to move into the newer situation. I told you culture is very, very sensitive to how you took it, how long you had it in bottle, what media you carried it, who processed it in the lab, where they put it, what type of incubation period was, et cetera, et cetera. And that's why there have been PCRs. This is Bill Costigan said that molecular techniques will be the way in the future. There's numerous PCR technologies available for diagnosis of infection, but PCR is very sensitive. PCR, you need to know what you're looking for because you have to design that primer. So unfortunately, that doesn't quite work. Next generation sequencing, on the other hand, is you sequence the DNA strands that were in that particular sample. You then run it against the phylogeny of genetic information on the NIH website, and then it tells you what organism it is. It can diagnose up to 40,000 organisms. Like here, a 14-year-old kid that goes to Wisconsin, he's in coma. He's obviously got a neurological infection. They do everything. They cannot isolate the organism. And then they send it for next generation sequencing, a spirochete, leptospirosis, similar to syphilis. NASA is using it. Multiple places have done. My first experience with this was very, very heartwarming. I sent the first sample. This was my own patient, had a knee done 4 years ago. Wife called me to say that the knee's swollen. He's in a lot of pain. So I asked them to come to the hospital. They couldn't come to Jefferson. They went somewhere else. They took the sample of the fluid. They called me. Obviously, the patient is infected. Culture negative in that institution. Patient got transferred. We did the same. I took him to the OR, took his implant out, pure pus, culture after 2 weeks negative. And when we sent it for next generation sequencing, Streptococcus canis, an organism that lives in the mouth of dogs and cats. And when we talked to the family, what we found was that his knee had been scratched and the dog had been licking it 2 weeks prior. So direct transfer of pathogen from the dog's mouth to the knee in this particular patient. We finished a 2,000 patient prospective study, and you will see more and more of these coming out. I will tell you in closing 3 things. One is that next generation sequencing can isolate organisms in culture negative in 90% of the cases. So if you have a culture negative, it's worth thinking about next generation sequencing. The second thing is that the list of organisms have been increasing in terms of causing infection. Don't assume just because you don't recognize the pathogen, it is a contaminant and it cannot be an infection. No, quite the reverse. Any organism you see could be. Like you will get a list such as this one. I realize there's a lot of organisms here we don't recognize, but don't assume in an infected case that these are not pathogens. My feeling is that really there is infection is caused by multiple organisms, and we just isolate the most dominant and we ignore the others because culture only isolates the dominant organisms. So moving forward, I think we will be using those. And as I said, I think infection is polymicrobial. So here, most of these can be treated with a single antibiotic. But what do you do with E. coli? Well, I think if you have an infected case, you should treat these organisms. And now we have data showing that when we did not treat the organisms that was on the next generation sequencing, they came back causing a failure at a later time point. So very interesting. And we are in the middle of a randomized prospective study on infected cases. One group is getting treated based on the results of the culture. Another group is getting treated based on the results of the next generation sequencing. We'll see if we're going to make a difference to that failure. At my institution, the failure of two-stage exchange can be up as high as 20%. So why are they failing, those 20%? Part of that is because we are not treating all the organisms that cause the infection in the first place. We're just treating the organisms that were isolated by culture. So those. And I will stop here and I'll tell you, I know we have a lot of time on our hands. If you haven't looked at this TED Talk, it's by Bonnie Bassler. She's the professor of microbiology at Princeton University. She's the person who coined the term quorum sensing. She's an incredibly smart lady. I am pretty convinced she'll win the Nobel Prize one of these days. That 40-minute TED Talk is definitely, 18-minute TED Talk is definitely listening to. So good luck. I miss you all, my friends. It's not going to be too long before we get together. Hang in there, stay safe. My thanks to Dr. Thakkar and all of you for allowing me to talk about diagnosis of infection. And I will stop here. Thank you very much.
Thank you, sir.
Thank
Thank you, sir.
Thank you, Dr. Parvizi. It was an excellent talk and eye-opener. Lots of questions we've already been receiving from the audience, those who have joined. Dr. Vaidya, can we have Dr. Akos's talk? Is Dr. Parvizi okay with you, or you would like to take some questions now?
I'm okay either way.
You can have a question when he's sharing the screen. That time can be used.
Just let us finish Dr. Akos's talk, and then probably we can have. Dr. Parvizi has been kind enough to agree to be here with us. So please, Dr. Akos, can you share the screen?
Great, Jay.
Yes.
Great talk. Mind blowing.
Meanwhile, while he's sharing the screen, let me just thank Dr. Yuvraj and Dr. Karthik, those who have been very instrumental, my co-moderators, for corresponding with both the foreign speakers and making them available for this webinar. They have also been the script writer for these next questions, which we are going to ask in the rapid fire. So I thank both of my co-moderators for that. Dr. Akos, all yours, please.
Thank you very much. Can you hear me and see my slide?
Yeah, we can do.
Yes, we can.
Okay. So thank you very much for the possibility to join this webinar. And it was I was very delighted to hear the first talk of Jay Parvizi, which was very interesting. And we follow the same strategy in the diagnostics, but it's always a pleasure to hear the new techniques and know about the new research on the field of prostate joint infection and see the presentations of Jay. It's fantastic. Thank you very much for that. And for me, it's very important to see the patients and consider the possibility of prostate joint infection. Of course, when you work as a joint infection surgeon and you see a lot of complicated cases, the first thing that you think about is PGI when you deal with a new patient and you try to find out what's the problem with the painful joint. In the most cases, it is not PGI. So in the most cases, it's aseptic loosening or mechanical failure. But until otherwise proven, I always think about the possibility of infection, especially in the first 2 years. And the clinical signs are not all reliable, as we saw it in the Philly consensus meeting, but the painful joint is the most reliable measure for you. So if you have a patient with an implant which is very painful, especially 2 years after surgery, without any other sign, you have to consider the possibility of infection. And that's why we go through the panel of diagnostic tools, as mentioned by Dr. Parvizi. We also go for a lab test by a blood test of the patient and then go for aspiration. And from the aspiration, we always go for culture. And you need a really good microbiology lab because otherwise you will have more than 20% of culture negative aspirates. And we try to keep this level as low as possible. So we have to go for a very accurate aspiration technique without having any contamination, and to have a very dedicated aspiration theater with an aspiration nurse, with fluoroscopy, with sterile gowns, sterile circumstances. When you have been to the endoclinic in Hamburg, where I've been working 8 years, and I was happy enough to have a lot of fellows from India, approximately 20 to 24 fellows from India every year. We always went to the aspiration theater to see how we do this, because it is very important technique. And leukocyte esterase, as demonstrated by Jay, we always do for that, because it's very cheap and very easy to carry out also in the theater. And of course, the cell count. Alpha defensin ELISA in the lab, and rather than using the lateral flow test. And we also apply the scores as presented by Jay in the previous talk. And as we know, everything above 6 is infected, everything below 3 is not infected, and in between 4 and 5 has to be investigated again. So this is how we find out which patient has to be treated with a prosthetic joint infection. And then you have to find out how you treat the patient. And nowadays, the discussion if 1 stage or 2 stage is better is not so difficult like 10 or 15 years ago, because all the surgeons, after all the important meetings of the last 10 years, realized that you need both of these techniques. You have patients who are happy with the 1 stage, and there are patients who are happy with the 2 stage. So if you work in a big center, if you are a surgeon offering complex revisions, you have to deal with both. Of course, two-stage revision is always possible, but as we heard from Jay, even in this big center, in the Rothman Institute, they have 20% of failure of the two-stage revision. And of course, the more complex cases are treated with two-stage revision. And that's why there is a tendency for more failure in these complex cases. In the easy cases, maybe they're picked up for one-stage revision. And these easy cases have a higher success rate. That's why we could say the result is more or less the same, something about 90% if you go for one stage or two stage. You can see here a patient 1 week after one stage septic exchange, and you can see the patient walking on 2 crutches, climbing the stairs without any limitation. So these patients are very, very happy, and they are very motivated to have a one-stage surgery. You can see the central venous line in the neck of the patient. So he's still on antibiotics 1 week after surgery, but he's walking as if nothing happened. And we have also evidence in the literature that the results of one stage are similar to those of two stage. So which one is better is not an appropriate question. The appropriate question, which one is to apply in which patient? Because two-stage revision has a higher mortality rate, of course, 2 surgeries, more complications, and some of the patients are not alive at the time of reimplantation. And also with the spacers, you may have issues like periprosthetic fractures around the spacer, or dislocations, or spacers which make no sense because there are remnants of the old cement, like in this case, or you can see in this case spacer which can not work properly in the patient. So it's not a good idea to keep the soft tissues of the joint, and non-articulating spacers, they are not a good solution. And of course, one stage is a cost-effective surgery, and you have a decreased morbidity and mortality, and it's very attractive. When you have been in the endo clinic, this is a photo of the septic revision theater number 1. We go for one-stage revision in most cases, 80 to 90% of the cases, when we know the germ, and we don't know the germ or germs, because in many cases you have 2 germs, then you go for 2 stages. So this is, the decision making is quite easy when you go for the culture. Otherwise, it's not so easy, and that's why we have to discuss all the cases in the multidisciplinary team meeting. 2-stage revision is indicated when you have no isolates preoperatively, or you have a difficult to treat germ, or you have some other problems with the anatomy. That's why radical debridement is not possible, or soft tissues not appropriate. And also with the 2-stage revision, the problem is when to reimplant. So if you get this question, when to reimplant, when is the 2nd stage to be performed, it is not always easy to answer, and there are no protocols. Of course, we go for reimplantation when the patient is doing fine. There's a nice soft tissue coverage, and the wound is okay. There's no fever, aspiration. We don't perform it, but the wound should be okay. So in this case, you can see a wound which is not okay. There is a big defect and an infection. So this is not a good case for one-stage revision, of course. In these cases, you have to go for a 2-stage revision in combination with plastic surgery, with the gastrocnemius flap and spacer. And also this case, in the chronic osteomyelitis of the patient, you have antibiotics. They are many, many years in the bone, and you can see a chronic osteomyelitis of the distal femur. In this case, you have to go for a 2-stage procedure. First, debride the knee and take samples, because you want to find out the germs. And you can see here the osteomyelitis with a bone cement. And then the bone was resected in a 2nd surgery, and the soft tissue was cleaned. and then was the reimplantation. In these cases, we go for mega implants to reconstruct. So the question is whether or not one-stage revision should be performed, but in which patient? So which patient? It is more selection of the patient. And sometimes you have a big expectation of the patient, but it's not possible to go for one stage. So that's why you have to talk about the possibility with your patient, and you come to your office and ask you for one-stage surgery. But when is it possible? Of course, when you follow the diagnostic criteria and you have a proven prosthetic joint infection, then the next step is the diagnostics. As we heard in the first talk, you go through all the diagnostic steps, and then you want to know about the germ and its susceptibility. If it's a fine germ and you have a known susceptibility and you talk to your microbiologist, you have a plan for local and systemic antibiotic treatment, then you have to answer if the soft tissues and the bone are good enough to go for single surgery. And then you can select your patients also together with your anesthetists based on the general condition of the patient. But poor general condition is, for me, not an exclusion criteria, because in these patients, especially in these patients, you can help a lot with one single surgery. And when you perform the surgery perfectly and you have good antibiotic treatment and you work together with your microbiologist, then you can help these patients with one single surgery with less morbidity. So when you go for one-stage revision, you need some key steps, which you always perform, regardless the joint, regardless the germ. And this is also one of the secrets of the revision in prosthetic joint infection, because when you go for one stage, you are more radical. So this is my observation. When I go for one stage, I'm always more radical than when I go for two stage. But to be honest, even in two stage, you should be always as radical as in one stage revision. So you have to excise all infected tissue and radically excise the synovia and parts of the scapula and parts of the dead bone, all foreign material, including cement, including old screws and washers and whatever, have to be removed, because small parts of foreign body may have a biofilm on the surface, and they may lead to recurrence of the infection. We always use a local antiseptic solution, I will talk about this later, to reduce the germs, and then we go for the reimplantation with some measures. In the knee, in India, you have more knees than hips. In Germany, we have 50% knees, 50% hips. We go for medial mid-vastus approach and to visualize the knee. Then you can remove the solid implants with the power saw. Doesn't matter if you go for one stage or two stage, you have to remove the implant, and you want to have as few bone loss as possible. So that's why you go in the cement implant interface with your power saw with a short and narrow blade, and then you can mobilize your implant and remove the cement, and then you can tap on the implant after mobilization. In this case, the femur was really good, very solid, not so easy to remove, but with your special instruments, which are easy to order, you can remove the implant without any bone loss. Any significant bone loss is to be avoided. In the second step, after removal of the implant, you want to resect the bone and make it clean. I use the power saw for this. You can see in this video how to remove the cement. This is a video from the hip, from the proximal femur. It's not so easy, and a lot of surgeons hate it to remove the cement. We always try to do it intramedullary without ETO. Of course, you can use also the ETO, which is a good method, but we try to avoid it. Or maybe in some cases, 5% of the cases we go for ETO. Otherwise, we remove the cement from the proximal femur intramedullary with special chisels and screwdrivers and corkscrews. When you have been in the endoclinic, you know all these special implants, I mean instruments, and how to use them, carefully remove the cement from the bone. As I mentioned before, you have to remove all of this cement and all of the foreign material. Then in the knee, we go for cleaning with the burr, similar to the dentist who is cleaning the cavity of the teeth with the burr, because non-viable bone has to be removed and the surface has to be refreshed. And then after cleaning the bone, you go for the cleaning of the tibia, remove the tibia on the same way to mobilize, and then to resect the bone and remove all foreign material from the tibial side, which is not so difficult in the knee, but more difficult in the hip. Then the posterior capsule has to be excised, which is quite tricky, and it needs some experience how to remove the posterior capsule because it's a part of the infection. Then we go for the antiseptic solution. We can use different solutions. We use this kind of solution which has an acting time of 10 minutes, and some others need less time. Sonication is an issue in some cases where you don't know the germ or you want to have a validation of your infection. We send the implants for sonication. It's not a routine procedure because our microbiology lab doesn't like it a lot, and we don't need it. We need the germ before surgery because of one stage, not after surgery. But sometimes when we go for 2 stage, we want to know the germ in culture negative cases, and then we send the specimen for sonication. You know all the advantages of sonication, it's needless to say. We use a polyhexanate solution, 0.04%, to clean up the joint in combination with jet lavage, but you can use also polyvidone ion or octenicept, whatever. You can see here the joint after cleaning, removing of the posterior capsule and removing all the infective tissue. This is a very impressive situation. Then in the 1-stage revision, we do 2 surgeries in one procedure. So we change the drapes. We go for a new draping. We go for new gowns, new gloves, new lamp holders, new suction tips, new instruments. Of course, you can go out and you can make a completely new setup. But in our practice, we follow the instructions of endoclinic and we go for a new setup. Reimplantation in the knee with a rotating hinge. Of course, when you remove the collaterals and the posterior capsule and a lot of soft tissues, it's better for the patient to have a stable knee with a hinge. As shown in this study, it's profitable for the patients to have a hinge. And we address also the bone loss in the most cases with trabecular metal cones or double cones, depending on the bone loss situation, and modular stems with femoral tibial modular stems. We always go for covering of the implants with antibiotic-loaded bone cement because we want to prevent the new implant from recolonization. Even in mega implants, you can cover all the implant with antibiotic-loaded bone cement, or as an alternative, you can also use a silver coating for the body of the implant. We always go to work together with a microbiologist. In the endo clinic, it was Lars Frommelt, who is now retired. And now in my new hospital in Berlin, I work together with Dr. Rüssmann, who is a very good microbiologist, and he has his own lab. So we work together with his staff in the lab, and we always get an antibiotic recommendation for both systemic and local antibiotic treatment. As you know, we use the antibiotic-loaded bone cement, the gentamicin, clindamycin bone cement, or the gentamicin, vancomycin bone cement, and we add additional antibiotics based on the recommendation. When you go for such a high dose of antibiotic loading in the bone cement, you are allowed to go for a shorter IV antibiotic treatment, as we learned from Lars Frommelt, who was our microbiologist in the endo clinic. Here you can see another case with a ruptured extensor mechanism and with a PGI, and you can see quite a bad situation with a lot of previous surgeries. And even in this case, we were able to treat the patient one-stage revision with reconstruction of the extensor mechanism and the joint, and the patient is happy and walks without walking aids, and he has also a good extension and flexion. So one stage in the proper patient with the proper technique is possible. This is another patient with a polymicrobial infection with a very bad situation. He didn't want to accept amputation. He didn't want to accept two-stage revision. He didn't want to accept anything. So we were forced to go for one stage, because normally you wouldn't do this case in one stage fashion. It was a very solid uncemented implant and it had to be resected. It was a very difficult situation. And also the soft tissue situation was quite challenging, but it was possible to reconstruct with a mega implant and a lot of antibiotic loaded bone cement. There is no extensor mechanism, but there is an implant in the knee, and the extensor mechanism can be replaced with orthesis. Of course, plastic surgery was needed to cover the big hole, and you can see with the orthesis, the patient was doing fine. In some cases, the extensor mechanism has to be replaced. It's not a good idea to do it in one surgery with one-stage septic exchange. In the most cases, we go for replacement of the extensor mechanism in a second surgery, when 1 or 2 years after one-stage revision, everything goes well, because it's an extensive surgery, as you can see here, and recurrence of the infection may result. There are some cases where we have to go for resection, and we are not able to do one-stage revision because of the bad soft tissue situation and also the bad bone stock. After a lot of surgeries, in this case, you can see very poor quality of the soft tissue, very poor quality of the bone, and had to be resected. There is no blood supply for the bone in this case, and the extensor mechanism had to be resected. In these cases, we go for arthrodesis and resection, arthroplasty, in order to have a good soft tissue coverage and to avoid the amputation. So one-stage revision is a radical surgery. It has less mortality and morbidity. We can go for shorter antibiotics treatment after surgery, 2 to 6 weeks, not longer, because it's one surgery, it's lower cost. Maybe it's an issue in India or in other hospitals, other countries, where the patient has to pay for the surgery, and maybe one surgery is more affordable for the patient. In 90% of the cases, when you have a good pre-selection of your patient and pre-selection of your germ, you can have a successful treatment in 90% and no second surgery is needed. In our practice, it is as effective as two-stage surgery, and the patients are happy because they have no impairment, and that's why we like it. Thank you very much for your attention, and I'm happy to get questions from the audience.
Thank you, Dr. Akos. I think we straight away start with Dr. Vaidya for his burning question to Dr. Parvizi. You need to unmute yourself. Shrinan, you need to unmute yourself. Yeah.
Thank you, Dipak, and thank you, Dr. Thakkar, for allowing me to be part of this very cherished group. It's always a pleasure to listen to Dr. Parvizi. I always say that what Dr. Parvizi has accomplished is nothing short of getting together a of joint replacement surgeon. Every time you meet and hear him, you're always charged for next 5 years till we meet in Philadelphia meeting. So with that, I have a question. Now this is in ACUS meeting November, there was a poster from your group which said that 90 days, the white cell count cutoff is 5,471. And we start with 30-day cutoff of 10,805. Jay, can you just enlighten us on this bit? Because it's so confusing. What you started off as 10,800 white cell count, if at 90 days cutoff, it is as low or almost half, I think there needs to be some directive in this sense, especially on the white cell count. So can you enlighten us on this bit?
Sure. Well, first of all, thank you so much, Shreen, for your friendship, for your guidance, for continued contribution to our field. You're incredible. And as are most of my friends in India, we learn a lot from you also when we meet. That's an interesting question you bring up. So what we have looked at is that the cell count after surgical procedure, uneventful or infected, we have then plotted that against time, and it looks like it's a fairly straight line that starts really high right after surgery and goes down to the level of around 1,000 or so by around 4 to 5 months. It does take a while for the cell count to drop in the synovial fluid. And these are only knees because unfortunately we couldn't do the hips. But I imagine it would be similar in the hips. And maybe Akos has experience because they do a lot in Germany of aspirating the hips, etc. So one is that cell count is really high right after surgical procedure, including those that are not infected. And two is that there's a decline in the value of cell count in the synovial fluid, which is dependent on time. Of course, there's individual variations, and there might even be ethnic differences, like possibly the Asians will have their cell count return back to normal earlier, etc. So that gives us another reason, and I know you were part of that conversation, and you're very privy to the argument from both sides. That would give us another reason to start to think about how we are going to dichotomize acute from chronic in the future. And it really has to do with other metrics than just time. So just because the cell count of 4,000 on day 91 doesn't mean the patient is infected, and a cell count of 2,900 doesn't mean the patient is not infected. So these are really complicated metrics that are influenced by a lot of other factors than just time.
Yeah, just one thing to add. I think there is nothing like acute, subacute, or chronic. I think it's all diluting, as you rightly said, and enhanced by other modalities, and especially I'm looking for the serum modalities. We can take a call. But I think 45 days, 30 days, and 90 days, these are all just figures. It's all about patient and the counts.
Exactly. I agree.
Dr. Parvizi, there's a question from the audience. Dr. Kulkarni wants to know how practical and how soon it's going to be commercially. proper to do the next gen sequencing test? Is it going to, and is it going to be commercially viable, and how soon it will come for the patients, and should it be done in all cases?
Yeah, excellent questions, all of them. And next generation sequencing is available in the United States. One company, again, I'm conflicted because I act on their scientific advisory board, called MicroGenDx, provides that service for all of us in the US at a cost of $200 per patient, not per sample, per patient. So even if you send 7 samples, they'll analyze them all and they charge you $200, which I think is very, very reasonable. It's similar to a culture would cost. That company does not have the facilities available elsewhere. Interestingly, there has been conversation going on with a couple of surgeons and my friends in India that have expressed interest in potentially bringing that technology to India through MicroGenDx or other companies. To do next generation sequencing is not difficult. You can buy a machine. Your hospital could buy it for, I don't know, $50,000. What is really important is the bioinformatics that goes with the next generation sequencing. The more samples they process, the better that bioinformatics is. So I feel that next generation sequencing will become standard of care in the next decade or so, if not sooner. It may or may not replace the culture initially, but in the long run, I think it will. Now, I didn't go into other fields because of the time shortage here, but there is New England Journal of Medicine paper on diagnosis of neurological disorders when they randomize patients to next generation sequencing versus culture. Very illuminating finding. Urinary tract infection, another very, very interesting area that's been explored extensively. ENT, etc. So next generation sequencing is not just for orthopedics. Other fields have actually been ahead of us and they have done it. So one is cheap. It's available in US, not available elsewhere outside US as far as I know, but the commercial entity that I know is planning to open a lab either in the Middle East or perhaps in India.
And on top of that, what you showed in a slide is a polymicrobial, the
Yes.
advantage of the next gen, because you've been able to isolate the multiple organisms. That's another advantage.
Yes, thank you, Dipak. So I just want to qualify what I said, which may have sort of, so we had an observational study on over 1,000 patients from multiple institutions. At the time of resection arthroplasty, samples were taken for culture and samples were taken for next generation sequencing. We did not take notice of next generation sequencing, treated the patient based on culture, which is the standard of care. And then we followed these patients for 2 years. Amongst them, 23% failed. When we looked to see what they failed with, 92% of the time, they failed by an organism that was there at the time of resection arthroplasty, and next generation sequencing had picked it up. So this whole concept of reinfection is actually not reinfection. It's persistence of infection by an organism that culture failed to isolate, and we unfortunately overlooked to treat.
Correct. Yes, Sharon. Sharon.
Ms. Parvizi, it's fascinating to listen to all this. We have been getting a lot more late infections, 4 years, 5 years down the line, and it looks like it's becoming a pattern. And next generation sequencing, will it also isolate your concept of intracellular bugs? And should we be thinking that they are the ones which are responsible for this late first time infections a few years down the line?
Sure, Sharon. First of all, I got jealous because I thought you were sitting in an airplane, but it sounds like you're at home because we're all missing airplanes, obviously. Yeah, great question, Sharon. Yeah, so doesn't matter when the infection happens, next generation sequencing from synovial fluid and/or samples of the tissue, it can isolate it. And some of these late infections, as we all know, are really not late infection. There may just be a subclinical infection that was sort of simmering along all this time. A second hit comes along, and then suddenly the patient manifests a clinical scenario. So it is even more important in those patients to do next generation sequencing, because what is happening in those patients is this polymicrobial existence of organisms that suddenly one becomes dominator, becomes the leader of the pack, orchestrates the whole clinical scenario. And if you miss the other small ones, you're not going to have an effective strategy. I think this is particularly important for people like Akash that does one-stage exchange, because in these one-stage exchanges, if you are just treating them by the dominant organisms, but there was a gram-negative organism that you missed, you could have potentially added antibiotics. I don't know, maybe Akash can answer that question, whether you are doing just antibiotic treatment directed towards the organism isolated by culture, or are you adding like dual antibiotics that will then help? So, and then I just published a paper, and I say this and we'll stop, with Alex Soriano from Barcelona. We looked at our cases, the two-stage exchanges, and interestingly, we looked at patients who had the resection arthroplasty done and antibiotic cemented spacer only contained one antibiotic versus dual antibiotic. Interestingly, the failure rate was so much higher in a single antibiotic group. Another testimony to the fact that we're dealing with polymicrobial infections, but we're using a crude and very primitive system, namely culture, to try to isolate this complex array of organisms that exist in collaboration. So I don't know if I answered your question.
Dr. Malhotra wants to ask something, I think.
Yeah.
And after that, Dr. Akos, we will hear from you what Dr. Parvizi is asking about the dual antibiotic.
And Dr. Sachin is also raising
I will
the
answer
finger.
it later.
Hi, Dr. Parvizi. I want to know your opinion about two things. One is we don't have next generation sequencing, but we have been using 16S rRNA, and we have picked up quite a few unusual rare infections caused by unusual bugs with that. And second, I want to know your opinion about that. And the second is the PET scan. I want to know what you think is the relevance of PET scan for diagnosis.
Sure. Rajesh, how are you? You look like, I don't know if that's your background or you really are sitting in Goa on that beautiful.
I'm stuck in Goa. Can't go anywhere else.
I wish I wasn't stuck there with you. Great to see you again. 16. So next generation sequencing is actually also uses the 16S sequencing, but it goes beyond just the 16S. It also does, as you know, the sequencing of the entire genome. The only issue with 16S and PCR is that it can sometimes pick up dead organisms or DNA, residual DNA material, which may not be truly representative of an infection. And in the context of COVID, if they are, I just sent you the document this morning, but there's been this talk about people who were infected with COVID being reinfected. One of the theories, and we have posited multiple explanations, but one of the theories is that your RT-PCR is picking up RNA fragments of the virus and not necessarily a viable virus that's alive, right? So that's the shortcoming of PCR, that it picks up DNA or RNA fragments and it will amplify it for you. So if you look at the PCR paper that I published, and I know Akash and the Endoclinic group also published on PCR, but I wrote a paper back in 2003 with Bill Costerton and Garth Ehrlich on the use of PCR, and we even did multiplex PCR. What we were finding was that about 60 to 70% of native primary joint arthroplasty that had never had procedure before, PCR was positive. And I'm not saying the organism was not there. They may have been there as part of microbiome. Now we're coming to understand, etc. But nonetheless, that makes the clinical interpretation of your PCR data so much more challenging. So what I would do with PCR, much like, there's been studies showing that sonification when you do PCR versus culture, PCR improves the accuracy, etc. Of course, PCR is much better. So in your situation, Rajesh, when you don't have the next generation sequencing available, I think doing 16S on some of those infected cases is a good idea.
Sachin,
The
your
cases
question?
that are infected.
Yeah, okay, I have a question. Maybe Dr. Akos can take this one. Especially in your patients on whom you're contemplating a single stage revision, are there any special strategies that you apply to the host, that is the patient, to try and ensure that you have a good outcome? And if so, if you have any special things besides the usual nutrition, proteins, hemoglobin, etc., what would they be?
Yeah, this is a very good question. There are some issues that you can change, and there are some issues that you cannot change. You cannot change the gender of the patient, because we know that male patients have a higher incidence of infection. You can optimize your patient. A patient can stop drinking alcohol and can stop smoking cigarettes. You can optimize the diabetes. You can optimize maybe the BMI of your patient with dietary measures, but it is also not realistic to achieve weight loss. But you can try to optimize the patient in order to have normal parameters, especially in diabetes. So the hemoglobin 1AC levels have to be optimized, and the soft tissues. So when the patient has a low hygienic environment and the skin is not perfect, this is not a good candidate for one stage, to be honest. But in these cases, the patient can optimize for the one stage procedure, because you need good general condition, you need good soft tissue coverage of your implant, and all the nutritive and comorbidities have to be optimized when possible. Not always possible, but in most cases.
Yeah. Dr. Rajkumar, you have a question?
Yeah, a question for Dr. Akash. Majority in your single stage revisions, almost all the cases which you had showed, in the post-operatively, it is the hinged processes which you have used. Whereas in a two-stage revision, we almost never we use a hinged processes in the second stage revision. It is a constrained process we use. Whereas in a single stage revision, is it deliberately you remove the collaterals due to radical debridement, or what it is? Because in a two-stage revision, very rarely we use a hinged processes at all after a cement space removal.
In Germany, we do use the hinges, especially in the endoclinic. You can also use a condylar constraint implant, and it is not absolutely necessary to remove the collaterals. But in the operative technique of the endoclinic, we always remove the collaterals in order to, because first of all, the collaterals are part of the infection, they are intra-articulary, and they are part of the capsule. So when you want to go for a radical debridement, you have to sacrifice these. The second reason why the collaterals are removed or released, that you want to approach the posterior aspect of the capsule, because the posterior side of the capsule is partly behind the condyles, and you have no access to this unless you release the collaterals. And third, these patients, they have pre-existing soft tissue problems and pre-existing unstable situations in the knee. So in these cases, the septic revision have a potential to damage the soft tissues, and it's much more reliable to have a hinge implant in the knee, because these patients have much quicker, much better recovery when they have a hinge. So our threshold to put in a hinge is quite low in Germany, to be honest. But it is also possible to go for a condylar constraint, but in many cases, the stability of the collaterals is underestimated by the surgeon, and secondary to the revision, patient may have some unstable situation, and then you go for a second surgery after this surgery, and it is not so reliable. So in these cases, we prefer going for the hinge, and we have very good long-term results even after 15 years.
So do you do frozen section in all your single stage revisions? Frozen section?
No. Frozen
Okay.
sections.
Dr. Parvizi, is there any role for frozen section in the eradicating PGI?
You need to unmute.
Yeah, I know. I was just, well, I mean, frozen section, if you have a pathologist that has expertise in interpreting musculoskeletal samples, and if you have all other parameters and you're sitting on the fence and the histology is going to make a decision one way or the other, then yes, maybe. But just to do it routinely and then act on it, if it comes back at 6 cells per high power field in more than 5 fields, and then you decide based on that histology to abandon reimplantation, I don't think that's supported by the literature. Yep. But if you're really one way or the other and you need another data point to allow you in to help you in that decision-making process, then I would say yes, there is.
There is a question for you, Dr. Parvizi, about D-dimer. Do you do D-dimer preoperatively in all the patients? Number one. And number two, in cardiac problems with thrombosis history, the D-dimer is usually high. So do you see the increase of the D-dimer? What is the interpretation, how we make?
Yeah, great question. So we have come to realize, based on educational letter that was sent to us from the Society of Pathologists, that apparently there is not a standard way of measuring D-dimer, and every lab does it in a different way, which adds to the complexity of using D-dimer as a diagnostic marker. The second thing is that apparently D-dimer measured in serum is better than plasma or blood, and not many labs really spin down the sample to get the serum. And then the third, to your point, is that D-dimer levels are affected by other conditions that may coexist. So if you look at our original paper that we wrote in D-dimer, we excluded patients with inflammatory arthritis, patients with thromboembolic diseases, et cetera, et cetera. So what do I think about D-dimer? I think D-dimer is a very useful marker. It's extremely sensitive. It is not as a specific. It carries a specificity of around 84%. Still as good as C-reactive protein, if not better. And that's why in the reimplantation cases, when C-reactive protein is likely to be still elevated, and ESR particularly is likely to be elevated, D-dimer plays a better role because the level of D-dimer comes down faster than ESR and CRP. So we're putting together an abstract for next year's academy, which I'm happy to share with you. We have over 120 patients who had D-dimer measured at the time of reimplantation. Again, this was an observational study, and some of these patients failed. Interestingly, there is a direct correlation, a very strong one, between the level of D-dimer at the time of reimplantation and subsequent failure. So if I have a patient that has very high D-dimer at the time of reimplantation, I would be slightly worried that that patient may still have persistence of infection.
Very useful information. Yes, Dr. Navin, you want to make some comment?
Yeah, there is a question from Dr. Jawar Jetwa for Dr. Parvizi regarding the quorum sensing. as anti-quorum antibiotic, the linezolid, how long we can keep for chronic infection under control?
Yeah, so the quorum sensing, it was an incredible concept that was put together with Bonnie Bassler, as I mentioned. And now she and other investigators across the globe are working on anti-quorum sensing technologies, which basically unravels the system by which the organisms are communicating with each other. And if you all know, last year, the antisense RNA was the winner of the Nobel Prize. When you can inject an antisense that prevents a gene from expressing itself. This is going to have huge therapeutic values for us. But while we wait that type of a technology to catch up, anti-quorum sensing antibodies are being tried in two fields currently. One is heart valve disease and the other is neurological disorder. And I'm watching those trials with huge interest. If such a thing is effective, then I think we could potentially be using them in orthopedics. So that's the quorum sensing. But if the question is also talking about using antibiotics to prevent quorum sensing, the answer to that question is not as clear and not as scientific. I am not sure what suppressive antibiotics do. We know that in some of these patients, when the suppressive antibiotics are stopped, they suddenly manifest a full-blown infection. So clearly the antibiotic was doing something, but I don't know whether it's working through quorum sensing, whether it's working through proliferation, prevention of proliferation, or whether it's working by keeping these inflammatory cytokines lower in the body so that a full-blown infection is not manifested. I know that's a long-winded way of answering the question, but that's all I know.
To make it simple, Dr. Parvizi, is there a role of chronic suppressive therapy in clinical practice? That's the general people want to know.
Yes, absolutely. I'm sure every one of us on this panel has a patient or many that we have decided that no more surgery, and I'm just going to keep the patient on chronic suppression. Yes, absolutely, there is.
A small announcement, 6857 is the hits. And 27 orthopedic surgeons are joined from Nigeria, 14 from the Kenya, Sri Lanka is 19, Bangladesh is 18, and UK 16. And Dr. Subhranshu wants to ask something, I think. He has raised the finger since long.
Thank
Subhranshu, you unmute yourself.
Thank you. Thank you, Navin bhai. Dr. Parvizi, it has been a very enlightening lecture. We have been meticulously following your diagnostic criteria since 2011. And now there's a new criteria in 2018. Now my question is that, there is a difference between the hip and the knee. Most of the time while aspirating the hip, you may not get anything, whereas in the knee, it is 95%, predictive of your aspiration. So while treating a hip infection, then have you done any study about to delineate a difference in diagnosis of the hip infection and knee infection? And number two, in the 2018 criteria, most of the time in the preoperative diagnosis, it is not possible for the hip side, so it will be intraoperative diagnosis. So what is your take on that? Second question for Dr. Arcus, that you have shown excellent cases in your presentation. You have a European criteria for European Musculoskeletal Infection Committee. They have got little different diagnostic criteria compared to AOS criteria. And which one you follow, and what is your rationale of following the European criteria?
Dr. Parvizi.
Thank you, Dr. Mohanty. As always, good seeing you and hearing your voice. Hip and knee has been, based on one paper, is thought to be a little different in terms of the threshold for cell count and neutrophil differential. And we don't know if that's purely to do with the fact that most of the hip aspirations are blood stained. And as you know, we've written a formula for correction of the white cell count when there's too much blood in the sample. So I did this analysis together with EndoClinic and with Rush, Craig Della Valle, and we have a paper coming out that shows that there is really not much of a difference in terms of the threshold between hip and the knee. And that's true for the acute, and it's also true for the chronic. And if there is, that difference is very, very minimal. So for today's it's today's sense, and also moving into the future, for the most part, we can just treat the hip and the knee the same in terms of the thresholds that we have. Your question is a great one, though, because hips are difficult to aspirate. The fluid either is not always available, or if it's available, is in a smaller quantity, and you're not quite sure which of those tests to perform. If I got a few drops from the hip, honestly, I would send it for neutrophil count, cell count and neutrophil percentage. That, in my opinion, has much, much more valid input in my decision-making than anything else, like culture, etc. So that's what I would do in that type of a circumstance. But these are great questions.
Thank you.
Akos, can you just answer the question what Dr. Mohanty asked you? And there is one more question for you. Is there a role of any uncemented implant in one-stage revision?
Mm-hmm. Yes. So first question was if we use the criteria of the European Bone and Joint Infection Society, EBGIS criteria. So it was not the MSIS criteria, but the EBGIS criteria. We worked together with the group of J. Parvizi in Philadelphia, and we have also a lot of discussion with our European colleagues. And we follow the criteria of the consensus meeting and MSIS criteria and the modified ICM criteria. And now we follow the scores. So we follow the American recommendations or our own recommendations, because EndoClinic was one of the organizers of the meeting. And we have always this discussion with our European friends. We work together with our European friends as well, but they rely very much on the cell count. And the basic of the diagnostic in the aspiration is the cell count. Of course, there's a role of the cell count, and we always go for cell count, and we know about the differences in thresholds in acute and chronic infection, and also differences between hips and knees and other joints. So it is a very important issue with the thresholds, but we rely more on lab techniques like ELISA with alpha defensin and combination of parameters. So we always go for PCR in the blood, culture in the synovial fluid, cell count with polymorphonuclear percentage, and alpha defensin ELISA. And we rely on these parameters. Second question, is there a role for uncemented implants? Yes, of course, especially in the hip, because in the knee, we go mostly for cemented implants, but sometimes we are forced to go for uncemented. But in the hips, we have the choice between cemented and uncemented. And we have also techniques for uncemented implants to cover with antibiotic loaded bone cement, or in combination with local antibiotics, or to have other antibiotic carriers in the joint. But we never use uncemented implants without local antibiotics, always in combination with any kind of local antibiotic treatment, mostly with bone cement or antibiotic bone grafts or any other local antibiotic treatment.
Yes,
okay. Dr. Parvizi, there are questions from Dr. Kirti Shah from UK. Do you have a suggestion on pre-op HB level, hemoglobin level, to prevent the infection? He has observed number of patients operated in India with low HB at a problem.
So is the question about hemoglobin A1C?
Hemoglobin, yeah.
Hemoglobin or hemoglobin A1C?
No, hemoglobin
only.
Oh, yeah, absolutely. Yeah. Anemia is one of the strongest predictors of subsequent infection. Yes. So
And
we would definitely have patients with anemia, if it's of unknown origin, to be worked up preoperatively to address anemia. If it's anemia of chronic disease like chronic renal failure, hepatic disorders, etc., it has been shown based on multiple studies that administration of a hematinic and/or erythropoietin to these patients to increase their hemoglobin level before surgery is protective against subsequent infection. And as you know, anemia also carries an all-time mortality. So one of the things we have not really taken good look into is the very severe and adverse effect of anemia on outcome of surgical procedures, including total hip and knee. I know in India, you're likely to see a lot of anemia related to ferritin deficiency and or vitamin deficiency. And some of these anemic patients could be treated very easily by administration of hematinics.
Dr. Karthik?
the next question is, do you regularly do serum fructose level? This is the question asked by Dr. Jay Shah, Mumbai.
Yeah, I do. Fructosamine is the one that we described recently. It's very simple, it's very quick to do, and it's very cheap. It's only $6. I realize fructosamine is not available everywhere. I'm not sure about India, but in cases where it's available, we do it. And we're about to finish the analysis on a 3,000 patient cohort, multi-center, when we did fasting glucose, hemoglobin A1C, and fructosamine, and looked at all-time complications and outcome. Fructosamine was the best predictor of those three in the postoperative period. So because of that, yes, we're routinely doing fructosamine on all patients undergoing arthroplasty. I'll just say one very quick sentence, and I think it's very important for you in India, because in the US, when we did a study on fasting glucose and hemoglobin A1C on about 1,000 patients of ours undergoing joint replacement, we found that there were about 12% of these patients who were either pre-diabetic or hyperglycemic, and these patients didn't know. I bet you that number is either the same or probably even a little higher in India. So because of that, we do fructosamine as a screening test. As you know, international consensus recommended that any person undergoing arthroplasty should have glycemia screening beforehand, regardless of whether they're diabetic or not.
Okay, one question from Karthik and then Dr. Vaidya.
Yes. Sir, if we have both intraoperatively and preoperatively bacteria different, so which bacteria we should concern? And second question is it necessary to re-aspirate if in two-stage implantation, if ESR-CRP comes normal?
Yeah, good question. I would be more inclined to rely on the intraoperative samples. They are more likely to be representative. And ESR and CRP still plays an important role for screening and also monitoring of these patients. So we would definitely watch the ESR and CRP. ESR and CRP can be normal and patient could still have a persistent infection, but usually that's subclinical. So valuable to do ESR and CRP in the two-stage exchanges.
Dr. Vaidya?
Yeah, Jay, I picked up a slide which says about TED Talk, and I'm really curious to know what is this TED Talk all about. I have a friend, a microbiologist, who keep on talking that bacteria do have personality and mind. So what's your take on that? That's number one. Number two, with your 3 decades of crusade with prosthetic joint infection, do you think in our lifetime, infection can become a bad word?
Those are great point. In our lifetime, will we ever have a situation where we don't get infection? I don't think so. I think that's going to be impossible. And all of us sitting at home right now because of this COVID issue is that we learn to live in harmony with the organisms. And when that equilibrium is disturbed, we then get into the situation of a clinical infection and or a pandemic. I will let the conspiracy theories still continue as to whether, you know, SARS-CoV-2 was a natural zoonite virus or whether it was manufactured in a lab. None of us know right now. Possibly any organism that's natural, exists in nature, will have the ability to get an upper hand on us as humans at some point and cause an infection. So will we ever live in a situation where organisms and pathogens do not cause an infection? I don't think so. I don't think that's possible. And there's a lot on, you know, infection right now in terms of the influence of viruses and other organisms in, you know, in our body, the microbiome and dysbiosis. Those are subjects of many of these TED Talks also. And I've been fascinated with the subject of dysbiosis and how disruption of that equilibrium can lead to diseases that we didn't even know.
Dr. Rajkumar, you need to
Yeah,
unmute.
The question is to Dr. Parvizi. Now with the NGS, I think you are able to isolate almost 90% of the time an organism. Even in a culture negative, PGI negative or situation, you are able to isolate 90% of the time by NGS. But the last 10% of the time where you are not at all able to isolate any organism, but still the joint is infected. What antibiotic you would prefer in this scenario, the current practice, and for how long, whether oral or IV?
Yeah, it's a great question. That was discussed extensively in the consensus meeting. How do you treat culture negative? And if I were to sort of quote you what was decided, that depends on three things. One is that whether you have a suspicion for the patient having a fungal infection or not. And patients who've undergone multiple surgeries, have received multiple courses of antibiotics, come from regions with a high fungal infection rate, those patients may have a fungal infection. And in those patients, you may want to take another sample, send it for specifically for fungus, and wait. And if you still cannot isolate the organism, then maybe you should think about treating them with a fungus as well. So that's that complicated question. But now, if you don't suspect fungus, then you should definitely consider treating the patient with both gram-positive and gram-negative coverage, so dual antibiotic. And that was the recommendation of the ID physicians during consensus. Treat them with intravenous at least for 2 weeks, maybe 6, but 2 weeks of intravenous followed by oral for another 4 weeks. The group of patients that I find very challenging, and I think those are the group of patients that constitute the culture negative, are patients that are infected by very unusual organisms, like Streptococcus canis that I told you, like Burkholderia cepaci, like the Corynebacteria and other organisms that we had never assumed they could cause periprosthetic joint infection, but they do. And like atypical mycobacteria. I had a patient of mine that NGS identified the organism. This person is the father of the professor of microbiology at Stanford. And it's interesting, the patient lives in Philadelphia, the son lives in Stanford. I even sent the samples to him to isolate the organism. They couldn't. And this patient has been suffering from infection for 3 years. NGS picked up an organism called Mycobacterium abscessus. Have any of you ever dealt with it? It's a terrible organism, incredibly aggressive, very, very difficult. So the issue I have is in some of these culture negative cases where the organism may be so atypical that giving them tobramycin and vancomycin may not do the job. And Mycobacterium abscessus didn't respond to any of those anyway. So we have a challenging problem. So what I have challenged the CEO of Microgen DX to do is to try to find ways where we would be able to isolate the organism in those 10% of the cases. And I think we're going to get there.
There is a question to you, Dr. Akos, further to what Dr. Parvizi said. Do you think that atypical mycobacterial infection and fungal infection are not suitable for one-stage revision?
Yes, I think so. Of course, when you do a lot of septic revisions and also a lot of one-stage revisions, you can try to go for these difficult germs to treat with one stage, but I don't recommend to do so. You can go with straightforward germs like staph epidermidis or even C. acnes. You can start with these germs when you can treat and you know how to treat them locally and systemically. Of course, there are some successful cases, and we have also a publication of successful treatment of fungal infection from the endoclinic with a series of 20-something cases. But this is not a good case to start with.
Okay. Dr. Navin?
Yeah, the question is, Dr. Parvizi, which bacterial infection you believe difficult to eradicate where you don't want to re-implant the joint? Your decision is you're not going to re-implant the joint.
Yeah, I mean, honestly, that's not an organism question. That's a complex decision that takes into account the age of the patient, their comorbidities, the state of the bone, the stats of the soft tissues, their prior history of infection, which organisms, how resistant they were, their expectations from life, their family's expectations from life. So it's not an organism dependent, this question. It is really all of those. However, if you really, really put my foot on fire and say, no, you've got to choose an organism, then I will say the fungal infections are the ones that I would be very reluctant to do multiple operations on these patients. I'm not saying every fungus I would seek a salvage operation, but if I were to choose a salvage, is mostly in patients who've had a fungal infection. Very challenging situation.
There's a question for Dr.
I may answer this because
yeah.
I agree with you absolutely. I did also one-stage revisions in fungal infections, but this is really, really very difficult to prepare, to make the preparations, to optimize the patient, to find the proper antifungals. These patients have also an immune compromise situation. So these patients are not to be operated with one stage, only if you have a huge experience with this and you have a very good background with your microbiologist. So don't do that.
There's a question for both of you. Is there a role for antibiotic in the cement in a primary case where patient is either immunocompromised, HIV, or some other risk factors? Do we use antibiotic primary case in cement?
Akash, do you want to answer that first?
Of course, the question is...
I didn't hear the question, sorry.
Okay, they're talking about, yeah, if there is a role for use of antibiotics in cement during a primary. Okay, so again, many of you know from the consensus, this was one of the other very, very hotly debated subject. I will give you my opinion, and then I will let Akash and others weigh in. The answer is yes. There is a role for adding antibiotics to cement in some of these primaries. And those are primaries that are very high risk for infection, including those that you just highlighted. The two facts that still remain, and we have to be cognizant of those, is that antibiotic impregnated cement is more expensive and places a huge burden on the society, especially when it's pre-mixed. And the second is that the result of whether an addition of antibiotics to cement prevents infection or not is still not shown. I know you're going to say, well, registry data, this and that. None of those are really reliable. And the 2 or 3 randomized prospective study that have been done did not show protective effect. However, in patients when the infection risk is so high, I don't think it hurts by adding antibiotic to cement. I'm just against the routine antibiotic impregnated cement use because of the facts that I mentioned.
Okay. Dr. Akos?
in Europe, especially in Germany, we use antibiotic-loaded bone cement routinely. So every single total knee, every single cemented total hip is operated with bone cement which contains gentamicin. And in the revision cases, in the aseptic revision cases, we also have a tendency to use dual antibiotics in cemented revisions with gentamicin, clindamycin, or gentamicin, vancomycin combinations. Because we have, despite of preoperative aspirations and despite of diagnostic workup for prosthetic joint infection, we still have a percentage of maybe 10 to 15% of the patients who are considered to have a aseptic loosening, but in fact they have a culture negative infection. And in these cases, it is reasonable to use dual antibiotics. In the special cases of prosthetic joint infection, when we know the germ, but even if we don't know the germ, we always go for a dual or triple antibiotic combination in the bone cement, because we want to protect the new implant from colonization, and we want to have a local antibiotic treatment. But we use also antibiotic-loaded bone cement in Europe routinely for primaries.
Sachin, your take on this? Do you use antibiotic cement routinely?
Not really, for sure. I think after being with the consensus meeting in 2013 and again in 18, I think we've gone away from using routine antibiotics in cement. Probably the only place where I might think of using it is in someone who's got inflammatory arthritis or someone who's got immune compromised status, in which you just want to be doubly sure.
Yes, Mohanty.
Yeah. My question to both Javed and Akash, that coming back to the chemoprophylaxis, what you give to these patients, what are your indications and how long you give chemoprophylaxis? For 2 years, 5 years, lifelong, and what antibiotic you select for the chemoprophylaxis?
I'll let Akash answer that one. He has much more experience.
You mean for the recurrence of the patients?
Yeah, chronically infected patients.
Yeah,
or recurrent infection. Yeah,
these patients, they have a prophylaxis with intramuscular penicillin for 6 months. In the streptococcal infections, they have a depot injection every 4 weeks for half a year. That's the protocol we are following.
Okay. Dr. Parvizi?
Yeah, similar, but sometimes we do actually give it for 3 months and then stop. And that's the study that we did with Corregdale Valley that just got published. So 3 months also seems to be protected, but I agree with that question. The complex ones I worry about, we go for 6 months.
These patients have mostly a bad soft tissue coverage in the lower leg and chronic venous congestion and not an intact skin. And I think in the most cases, it is not possible to optimize the soft tissue and the skin within several weeks. So that's why I feel more comfortable to treat this patient for 6 months.
Sharon?
Going back to the next generation sequencing, does it also give us the sensitivity profile? What antibiotics will work on what bugs, to what extent?
Yeah, so that's been one of the criticisms of molecular techniques, that it doesn't give you the susceptibility of the organism. But fortunately, with time, there has been great advances where the gene that modulates the resistance is now also detectable by either next generation sequencing or PCR. So for example, to tell the difference between methicillin sensitive and methicillin resistant Staph aureus, they look for the MEK gene. to tell the difference between vancomycin resistant enterococcus versus vancomycin susceptible. They look for VANC-A gene, etc. The criticism that you might hear from your microbiologist is that, well, yeah, the gene being there isn't a confirmation that the resistance is expressed. True, but if I have a next generation sequencing data that shows me that Staph aureus DNA was identified and there is a MEK gene, believe me, I want to treat that as methicillin resistant staph. Whether that gene is expressed or not, I would err on the side of taking note of these resistance genes. So the answer is now there's about 270 different resistant genes that they look for, and they're using very clever neural networking and AI to come up with projections on which antibiotics you should be giving the patients. So the report we get from MicroGen-Dx actually not only has the organisms, but it also gives you by projection which antibiotics we should use.
Fascinating. Can I just ask the last question? This intracellular bugs, do the antibiotics what we give go and affect them? You're talking about intracellular organisms which are embedded.
Yeah, it doesn't. So rifampin is thought to have some intracellular activity, and that's part of the reason why rifampin-related data from Europe in particular looks promising. There is a Chinese company that we're working with, and I have no conflict of interest, no financial interest here, a company that has a rifampin plus a chloroquine, I've been listening to President Trump too much, I think. I keep saying chloroquine. And rifampin-based combination antibiotic has intracellular activity. They finished their phase 2. We're about to start their phase 3 clinical trial when we also start the elective arthroplasty. I do think that the future is definitely going to be an antibiotic that has an intracellular activity, to your point. Absolutely.
Dr. Rajesh.
Yeah, I mean, just to add a little bit to what Dr. Parvizi said, that in India for tubercular resistance, we are mapping these genes for INH and rifampicin resistance by line probe assays, the same way to identify the gene. My question is to Dr. Akos, and we are all quite aware that the megaprosthesis is more prone to infections, and I can see you use the silver impregnated or the antibiotic coated coating on the prosthesis. Two questions here. One, are you comfortable, because once the antibiotic leaches out of that cement, you got this big layer on the prosthesis which is really not going to do anything? And second is, do you ever use something like stimulant for antibiotic delivery, because it just is biodegradable and it just disappears?
Yeah, this is a very good question, because the role of the antibiotic loaded bone cement is only for several weeks on the surface of the implant, of your mega implant. And I would be more than happy to use antibiotic carriers which dissolve. But in Europe, in Germany especially, we are not allowed to use the stimulant. And the stimulant is not given free for the German market for any reason. I don't know why. And that's why we don't use it. We use antibiotic-loaded bone cement, which has only traces of antibiotics after several months. And we need the antibiotics only in the first 4 weeks, I would say. Advantage of the silver coating is that it can remain in the body, and it has a long time antibacterial potential, but there is also a toxicity of silver, as you know, and that's why the unlimited use of silver implants is not possible, and only coatings are available. And that's why we don't use it routinely. But without antibiotics and without silver coating, you have complication rate of 20 to 25% with the mega implants. So it is very important to have a very meticulous technique in the sterile environment and a local possibility with silver or antibiotics to prevent the implant from recolonization.
A very quick comment. My objection to a coated implant is that you can never coat the articulating surface and the bearing, and that always is the area which is susceptible and going to give you problem.
Yeah, that's why we combine.
The question is
combine with cement. Yeah.
Question is to Dr. Parvizi. For a presumed aseptic revision, are you doing intraoperative leukocyte esterase test?
Yeah, all the time. I do it all the time.
Yeah, me too.
Yes, Dr. Sharan.
Yeah, I think I'm just getting very greedy to ask all these questions. Ms. Parvizi, there's been a lot of talk about nanotechnology, where we coat these implants, which will form a mechanical barrier and break the cell membrane and never allow the bacteria to settle over these surfaces. Like some of the animals, wings never get bacterial infection.
Yep.
So what is your thought on that?
Yeah, it's a great, fascinating technology. I work with a company in Australia. I've been working with them for 3 years that have been using the wings of the dragonfly as the nanotubule structure. As you know, that was actually published in scientific reports in Nature. The technology is started by a Russian investigator in Spain, and then Australian companies acquired it. The initial in vitro data looked fascinating. The animal studies looking incredible. And I'm helping them right now with the process of going to FDA for potential approval process. So whether it's the dragonfly's wing or whether it's something else, I think surface modification by the use of nanotechnology to get nanopillars that makes it resistant to bacterial adherence is definitely very promising for us moving into the future. So it will be technology like that, as opposed to adding antibiotics to cement. That's going to be the winner.
One question. My question is that we are talking about rifampicin and quinolones. Those are quite effective also for the biofilm and commonly used probably after a DAIR. In India particularly, we are worried about rifampicin resistance because we have still tuberculosis is rampant in our country. So how can we avoid rifampicin in this kind of cases? Is there any alternative to that?
Kosh, do you want to answer that one?
No, I cannot answer this.
So you're talking about anything other than rifampin that could have a promise? Yeah, I think that's going to be the new antibiotics, but not many companies are producing new antibiotics. I am personally very, very excited about the data by Tenor. That's the name of the company, TENOR. And that combined antibiotic looks to have amazing promise.
Are there any clinical data available about this Tenor?
No, yeah, so they have got the phase 1 and 2, and the phase 2 data looks incredible, and they're just about to start the phase 3. But there's a lot of preclinical data in the animals and also obviously in vitro data, but the clinical trial of phase 3 is about to start.
Unmute, Dr. Dipak bhai, unmute yourself. Unmute, Dipak bhai.
You can take the last question and then probably we can move to the rapid fire question.
There is a last question to Dr. Akos from a delegate. In one of the cases, you saw the skin loss in the knee implant, exposed implants. How do you use the VAC dressing there? Vacuum assisted.
So if you go for one stage revision, your soft tissue has to be intact. So that means if there is a big hole in the knee and there is a defect or any kind of skin defect, one-stage revision is not a good solution. If you have a draining sinus, which is lined up with your scar, and you can remove it and you can reconstruct the soft tissues immediately in the same surgery, then it's not an issue. Otherwise, it's an issue, and otherwise I would go for a two-stage revision, because I want my implant to be covered by several layers of soft tissues, by capsule, by muscle, by skin. If you have a defect, one-stage revision is very, very difficult to carry out. In some cases, you can use VAC only for several days, but then immediate plastic revision, plastic surgical reconstruction with the gastrocnemius flap or whatever flap is needed. So VAC therapy has no role in one-stage revision, only in exceptional cases.
Okay, I think Dr. Parvizi and Dr. Akos, only we were knowing that you had limited time allotted to us earlier, 1 hour. Our faculties were knowing, and we all were knowing, not all the delegates were aware that you will be available to us for almost 2.5 hours. It's an excellent contribution from both of you in terms of your time, your inputs, and the excellent talks by both of you. We are going to carry on the next half an hour for the rapid fire questions, which is taken from the ICM books only. You're very happy to be there if you can stay, but we are happy if you want to leave, because I think both of you have really overstretched your time. On behalf of Gujarat Orthopedic Association, all the delegates from so many countries, especially from Nigeria, Kenya, UK, Sri Lanka, and Bangladesh, and all Indian colleagues, and my faculty colleagues, those who are here, I really thank you very much for spending so much of time with us. Instead of 1 hour, both of you stretched to 2.5 hours. I really thank you and appreciate your inputs and efforts. Thank you very much.
Thank you.
Thank you very much.
We are very much thankful from Gujarat Orthopedic Association, both of them.
Thank you very much. Thank you. Have a good day.
Thank you
Yeah,
so much.
thanks, Jay. Nice talking to you.
Thanks, everybody. Keep safe. Thank you very much.
Be safe, be indoor.
Thank you.
Yeah. I request other faculties to be there. We just quickly take for half an hour. It's already 8:25. We take half an hour quick fire questions, which are common for the most of the orthopedic surgeons. So one by one, I will ask the questions, and we just start now. It's like a rapid fire round. Okay, the first question to Dr. Vaidya.
Yes.
Is obesity can be a factor for
infection? Yes, BMI more than 40, definitely.
What is the your threshold value for that?
BMI 40.
BMI 40. Dr. Sachin, do you always do bilateral in obese patients, or you would resist?
It depends upon the absolute, from a PGI perspective, we know for sure that if you have obese patients, then the risk of getting PGI is higher. However, if you optimize the patients properly prior to surgery, then the risk can be mitigated to those of non-obese patients.
Optimizing, do you mean that they should go under bariatric surgery?
It's questionable, and it's a debate whether the bariatric should come first or the knee replacement should come first. There's enough evidence now that if you do bariatric surgery early, before the knee replacement, then these patients do go into a sort of metabolic immune compromised status, which may actually increase the risk of having PGI after your knee replacement surgery.
Correct. Excellent. Next question to Dr. Rajesh. Reverse to that, we have already seen and answered by Dr. Parvizi about the low hemoglobin, but undernourished, malnourished patients with low albumin, do you think they have a high risk for infection?
Yes, I agree that the underweight patients do have a high risk of SSI.
Correct. Okay. So the answer for that is yes. We already asked this question, but it's slightly modified. Dr. Rajkumar, do we have to stop the anti-rheumatoid drugs like methotrexate or HCQS before the surgery? And what about the biologics? What is the current evidence about these drugs before the surgery?
Yeah, it is definitely, it is better to stop before the surgery, at least a week or two, and again it can be restarted after 2 weeks after the surgery, preferably after suture removal. Once the wound is healed well, then we can restart. So better to stop.
You have any suggestion on this?
No, the consensus meeting certainly suggests that we should stop, but we have had some difference of opinion with our rheumatologist. They have no problem with continuing with methotrexate while biologics and other things have to be stopped. I know that the consensus meeting says we have to stop it.
Correct. So I think the recent guideline is that methotrexate and HCQS can be continued, but all the biologics should be stopped before the surgery. What Sharon just added on what Dr. Rajkumar said. To Dr. Mohanty, preoperative urinary tract infection, symptomatic and asymptomatic, will it increase the risk of subsequent PJI?
The answer is yes. If the patient is symptomatic, then the patient needs to be treated with antibiotics before surgery. But if the patient is asymptomatic, then now we need to see that what is the colony count. If the colony count is more than 1 lakh per ml, then the patient needs to be treated. And if less than 1 lakh, we can go ahead with the surgery without putting them on antibiotic prophylaxis.
Dr. Vaidya, do you do routinely catheterization in your patients with single site surgery or bilateral surgery? Do you do the urine catheter?
Never. Urine catheter, indwelling, never. If required, simple rubber and get out if the indications.
Right. So the asymptomatic bacteria.
We do in bilaterals urinary catheterization for 1 day. Okay. Or else if the patient is post-operatively is not able to pass urine, then just temporarily we do catheterization.
Right. So the recommendation is that asymptomatic bacteriuria and treatment should be discontinued, as Dr. Mohanty said. And the question which Dr. Vaidya just answered, that usually we should try to avoid doing the catheterization, except in some cases like bilateral, but intermittent catheterization is sometimes useful if you really need to do. Okay. Dr. Sachin, HbA1c, your threshold for that. I think that answer has been given by Dr. Parvizi about fructosamine and other things. So probably we just leave with this question and move forward. We also have asked about HIV. So Sachin, with the immunocompromised patient, what optimization should be undertaken prior to operating these patients?
So I think what you're looking at essentially is good inputs from your infectious disease consultant. If you have a medically optimized patients with low CD4 count and less viral load, then probably you should just treat him like anyone else. But someone who does have associated issues like the whole full-blown disease per se with hepatic or renal compromise or malnutrition, I think you need to take extra precautions in that particular individual.
Yeah, so I think it's a very important thing to optimize them and look for the renal and liver diseases and CD4, CD8 count and the viral load before you operate to reduce the chances of subsequent PGI, correct?
Yes. Yeah. CD4 count should be at least more than 200.
200, yes.
And one must remember that, CD4 count has got a diurnal variation as well. There is if you take the sample in the morning, if you take the sample in the evening, there will be difference in the CD4 count. So one has to consult the, HIV consultant before taking a decision. And the viral load has to be less than 10,000, per ml of blood, what are 10,000 types. So that will be reduced viral load.
Dr. Malhotra.
There's quite a lot of expertise in HIV, yeah?
Yeah, we treat a lot of HIV patients in the,
Leave it to the physician. Leave it to the physician.
Dr.
Don't break your head on HIV.
Does prolonged hospitalization prior to the surgery, elective surgery, will increase the risk? Should we admit the patients only in the morning for afternoon surgery or 2 hours before the surgery and not the previous day? Do you have any take on this?
Yeah, definitely. It increases the risk of infection. And if you have a patient who is sick, the best thing will be to call the patient in the morning of the surgery but that doesn't is not very practical in our setup. So if you have entire workup and the PNSAT check done beforehand, everything worked up, then admit just the night before, and that's much more practical, taking consent, preparing, doing everything, and minimize the period of hospitalization.
Correct. Okay. That's a point. Dr. Rajkumar, post-traumatic arthritis, is there any chances that the infection will be more prone for the PGI in these cases?
Yes, yes, definitely. Post-traumatic situations, the chances are very high. So we have to optimize the patient medically and also talk to the patient, counsel them very much that the chances are very high. Definitely, we have to be very careful.
Okay. Dr. Vaidya, prior septic arthritis of a native joint predisposes to the patient to an increased risk of subsequent PGI. And if yes, we know that, of course, if there is an infection in the same joint, how soon after a prior arthritis we can do the elective arthroplasty?
Well, I can quote you from a successful case that I've done. I think what is recommended is patient must be lavaged with an arthroscope debridement 3 times in 1 year. And every time you have to do culture, if all 3 cultures are negative, the safe time would be 1 year and nothing less than that.
Okay. Dr. Mohanty, you have to say something on this?
Yeah, if it is a difference between septic and tuberculosis and fungal, all these things what you have written, the things are different. Yes, it has to be differed. In case of septic arthritis, at least 6 months to 1 year. But if it is a tuberculosis, then we put these patients on the anti-tubercular treatment and we can go ahead with the surgery maybe after 3 to 6 weeks. But intraoperatively, if you find frank pus or the the tuberculosis or the granulation tissue has gone outflown out of the capsule of the joint, then better to treat with the spacer and then come out, treat with anti-tubercular treatment and take these patients after 1 year of taking out the spacer and doing a 2-stage treatment. In case of fungal infection,
can I add something there, Deepak?
Yes.
It's all okay to say that this septic arthritis patient will have to wait for variable length of time 1 year before we do it. But I've had many situations where these people are in tremendous pain and their life is crippled. In such situations, I've treated it like a 2-stage procedure.
Yeah.
Go in, resect, put an antibiotic spacer, make sure all the counts have come back to normal, and you go in and put in a prosthesis in 4 weeks or 6 weeks time. And I've had fairly reasonable results. At least I've got half a dozen patients with this kind of an approach.
yeah, similar treatment we have done. Then when you put the spacer, you take the cuts, don't take the notch cut or don't open
Absolutely.
up the medullary canal of the tibia and put the spacer. And for
Yeah, just
fungal
the
infection,
distal femoral.
yeah, fungal infection, one has to treat this fungal infection for at least 6 months. And after treating 6 months only, then you take a decision for doing a surgery in the second stage.
Okay. Dr. Rajkumar,
Yes.
Many of the patients usually ask, and we tell them that if they are undergoing any dental, GI, urological procedure, if they have a joint replacement done, should we really give them and tell them, advise them about role of prophylactic antibiotic before undergoing these invasive procedures?
Yeah, but see, it depends. In the consensus, they say there is no much of role for prophylactic antibiotics. But in our Indian scenario, we counsel the patient and ask them to tell their doctor, whoever is doing the procedure, and they can take a decision. But consensus-wise, there is no evidence for that.
Dr. Vaidya, would you advise your patient to start antibiotic before doing these procedures, which is very common?
Yeah, I think one has to segregate. Dental root canal, yes, I would say 2 days prior and 5 days afterwards, antibiotic routinely. Of course, as Rajkumar said, there is no consensus on this. Urinary tract and GI depends on what the procedure is all about. Any prolonged procedure, invasive, I think antibiotic coverage is safe. You can't redo things when things go to the joint. So I would rather give coverage of umbrella of antibiotic to make sure it supports the system well.
Dr. Sachin,
Yeah.
do you think that doing bilateral TKR is going to increase the risk of infection in the second joint which we do? And number two, if you are doing, would you use separate instruments for each side, or only draping and painting and draping again is sufficient? Your take on this?
So I think simultaneous bilateral hip or knee replacements will not increase the risk if you have an optimized host. If you have a compromised host, then yes, definitely that becomes an issue. I do not routinely advocate the use of separate instruments, and neither does the consensus meeting. You need to have a good team which can do your job very quickly and efficiently.
Do you just drape it afterwards, or you do both the draping simultaneously?
Both draping simultaneously. The side that is not operated first just gets covered in a sterile drape, which is then removed afterwards.
Okay. Question to Dr. Sharan Patil. Is there a relationship between the levels of airborne microorganisms in the operating room and the risk of prosthesis-related infection?
It's an obvious answer is yes, because more organisms airborne, the more likelihood of getting infected.
Okay, so I go further to that. Do you think that there is a specific role for space chute or laminar airflow? Would this certainly help to reduce the infection rate?
There's no evidence really to suggest that it certainly reduces the infection rate.
Okay. Dr. Vaidya, is there any methods available to verify the microbiological cleanliness of the operating room? Should we, and how should we check our OTs routinely and instruct the infection control specialist, nurse, or the microbiologist? What should they do? How should they check that the OTs are sterile?
Air changes, coarse filters, HEPA filter every 6 monthly, cultures from three areas in table and 2 areas in the washing. Every time, every fumigation time, you make sure the theta temperature comes to 18. If the filters are clogged, it is better they get washed every week. That's my routine, and it's a fixed protocol, and it is given to every place that I go.
Dr. Rajkumar, anything you want to add? Because I think very important to take the cultures from the washing area, as you said, and from every corner, not
that is what
surfaces or walls.
Very important is multiple cultures from even from the operating table areas, lights, and wherever a lot of things are stored in the theater, those areas it has to be taken.
There should be air sampling also from the anesthesia trolley, from the table, and from cupboards, whatever is there all around the theater. From every place, culture should be taken.
Yeah, I think this question doesn't need any answer. The number of
Yes.
individuals, so we certainly needs to reduce the traffic. The other two questions about the personal suit and the laminar flow has already been answered by Dr. Sharan Patil, that they certainly do not demonstrate to reduce the chances of infection. To Dr. Rajesh Malhotra, use of this, we have been seeing a lot of our OT staff wearing the dress outside the operation theater, in the wards, especially the anesthetists, they go with the same dress and then come out. I don't know whether they change or not, but is this a good practice, and your advice on this?
It's an absolutely no-no, and I have strict instructions in my department and in trauma center that I don't want to see anybody going out in the OT attire, sitting in the and having the OT clothes. And you know what? If you just allow them, even if some of them say that we will change when we go back inside, it's not allowed, because you can never check whether they really change when they come inside or not.
Correct.
So it's a no.
Correct. Good. Dr. Karthik, a question to you. Do you think that patients wearing mask and the cap in the OT would help to reduce the risk of infection? Dr. Karthik?
You have to unmute, Dr. Karthik.
Yeah, hello. Yes. Yes, sir. That makes a difference. If patient is wearing the mask and a surgical cap in the operating room, but concessions, I don't know what are the actual concessions.
Sachin, usually in the females, we see that we make them wear the cap because of that hairs. But do you think this is a good practice for the male patients also?
So I think you need to know what the explanation behind this question and how this answer got formulated actually. In the consensus meeting, besides surgeons, there are lawyers who also attend. And to prevent any unnecessary litigations, these were the questions that were sort of answered deliberately in this particular manner, because the consensus meeting did not want to give out statements like, it's okay if you don't wear cap and mask. However, there's no evidence, but I think it's a safe clinical practice. One could always follow. You will never lose if you do that.
Correct. To all the faculty.
Can I make a comment, Dr.
Yes.
Deepak?
Yes, Rajesh.
Yeah, so I think it's very pertinent that I make this comment at the present moment, that because of the COVID, now it's imperative that you make the patient wear a mask, although it's not required as per the consensus meeting, which required only the cap. But I think the mask for the patient or the special suit for the surgeon, both are relevant at present moment, because all they do is to protect the surgeon. And that is what is important, not from the point of view of infection to the patient.
And I think, as Sachin said, we'll have to make a habit and a practice. There is no harm in this. So probably it's good. I just want to tell all the faculties, would you be please happy to continue? Because even now at this moment, we have 6,990 people linked to the webinar at the moment. So these questions, I'm slightly going little fast deliberately to cover little more subjects. That's the only point. So if you are please happy, let us continue. Yes, Vaidya.
Yeah, I just to add one more point. This conventional wisdom in a consensus vis-a-vis the opinion that is drawn from it. Now, 2013 meeting, European group was heading the laminar airflow and theater traffic and things like that. And it was concluded laminar airflow is not needed. Now, Deepak, in a country like ours, once you say laminar flow is not needed, you think general surgery theaters are good enough to do knee replacement or hip replacement? So I vehemently put this point down. Laminar flow at least makes some benchmarks, some coarse filters. So I think Sachin was right. The way the questions are framed in consensus may be little for a particular geographical reason, a particular geographical necessity.
Yeah, there is no doubt about that. But the point is, as what Dr. Rajesh was saying, that air traffic, not wearing the proper OT dress, people, anesthetists not wearing the mask and the cap properly, people are...
I endorse Rajesh totally. I think in COVID has really awakened us about all this.
So those are the very basic things which we should follow, I think.
Absolutely.
Correct. Okay. Karthik, light handles. You think we very frequently use to adjust the light? Is this a good practice to do?
Yes, sir. Light handle helps in the surgical field, but make sure they are properly sterile, autoclave. But I think consensus is unknown on this.
I think they say, Dr. Rajkumar, what do you advise frequent changing? Because it's not a good idea to change it frequently with the light handles. You agree with that?
No, light handles, definitely it has to be sterile because we touch it very frequently. And if the procedure is too long, like in a revision procedure, there is no harm in fact changing. When you're changing the gloves, better to change that also if there is a possibility. So light handles, yes, absolutely, it is very, very important.
Okay, so let me ask you that further question. How frequently you would change the gloves?
Gloves, see, according to the consensus, 1 hour, any procedure more than an hour, it says better to change. In a primary situation, you may not change, but if in a revision scenario, better to change in between whenever you think that you're going to use after a debridement, after a wash, you are going to use an implant, that you are going to do the implantation, that time to change, or while just before the cement mixing the cement, that time it is better to change. In a primary, you may not need to change routinely unless otherwise just before the cementing. Some surgeons do it before cementing, otherwise not needed. But in revision, yes, better to change.
After draping also, one need to change the outer pair of gloves.
Dr. Sharan, apart from gloves, any suggestion on suction and the cautery tips if the surgery is prolonged? What do you think about those suctions and the cautery tips?
I don't think I have had the practice of changing them. I'm not quite sure of this really. Yeah.
Dr. Vaidya?
Revision all the time after 1 hour, routinely no, because surgery gets over sub 1 hour.
You change the suction tip and with the cautery tip?
In revision after 1 hour.
In revision after. Dr. Rajesh?
I think the biggest risk factor is the prolonged surgery. Whenever a patient comes with infection, I ask how long did the surgery last. So I think things start going bad when the surgery is going too long. So it's better to take a precaution of changing these things, because otherwise also the risk of infection is rising.
In bilaterals, I change the cautery and suction tip and light handles after the first knee.
And I think it's a good useful tip for the bilateral. We should change the suction tip, cauteries and the light handles when we do the second side. Dr. Sachin, do you have a practice of giving the skin cleansing, the wipes, the chlorhexidine wipes to the patients at home? It's a very simple, useful thing and not very costly also. Do you think that patients using this at home would certainly make a lot of difference?
It has certainly been recommended in the consensus meeting that this will definitely decrease the incidence of PGI. The way I follow it is that my patients get admitted the night before and they have a bath with chlorhexidine soapy solution, and that's what we follow the night before if they want, and definitely in the morning for sure.
Yeah, I think it's a very good thing to use the wipes because it's easy. The patients themselves can use it the previous night and just before the surgery also. Dr. Rajkumar, do you have this practice in your hospital?
Yes, yes. Like as Sachin said, our patients get admitted the previous day night. So they have a bath with the chlorhexidine solution. In fact, it's being practiced even in the spine team also. They have in fact done a study that even in spine procedures, it reduces the chances of infection. So all elective procedures.
We tell our patients that when you take bath, you clean your perineal region, groin, and foot and ankle. Many patients also, they never use slippers at their home. So we tell them that you clean it before the surgery, and after the surgery, we recommend that you use slippers at home.
What is the practice, Dr. Sharan Patil, for the hair removal in your? Do you just remove in the OT and if just with what?
OT. Yeah, we remove in the OT with clippers.
Okay,
just
so
before the surgery.
Very common and a very useful thing. Don't use the shavers. Clippers are better, or the cream, and just before the surgery in the OT. Am I correct?
Yep, that's exactly what we do.
Okay, fine. Skin preparation, Dr. Vaidya, is there any specific thing which you should look into when you do the skin preparation?
I personally opt out for chlorhexidine. The consensus goes in favor of chlorhexidine. I used to be povidone iodine before, but I think last 3 years I have turned to chlorhexidine. There are reports which favor it.
Right. I think as long as it has got isopropyl alcohol as a part of preparation, which is very important. Yes, Rajkumar?
Yeah, the one small point here is if you're using a chlorhexidine with the alcohol solution, you have to be very careful that the solution doesn't get stagnated over the thigh region or in the gluteal region, because once you use a cautery, then you can have a very bad burns around particularly when you have applied a tourniquet, this chlorhexidine solution can go and get seeped into the tourniquet one, and that will cause burns, and it's very, very difficult to treat that. So you have to be very careful when you are using a chlorhexidine solution.
Okay, all right. But you think that the isopropyl alcohol combination has to be there?
Yes, it has been proven that it is quite good, but you have to take precautions.
Correct. Okay. Now, after you do the draping, do you think that additional skin cleansing is required after the draping, Dr. Sachin?
Yes, of course, it definitely adds to the safety of the procedure, and it has been shown with the consensus that there is good evidence that if you use skin cleansing afterwards, it is definitely useful.
Correct. Okay. Right. We already discussed this section tip we have done. Okay. Dr. Mohanty, irrigation solution. What is the best thing to use and how effective it is? Like after doing the knee replacement implantation, do you use anything to irrigate the joint? Like
yes, irrigation solution reduces the intraoperative bacterial count to the tune of 12 to 56%. Hence, irrigation solution should be used. I use normally diluted betadine solution. It is about 10% povidone iodine, 20 ml mixed with about 500 to 1000 liter of normal saline. But one has to be careful when you are using these irrigant solutions that you should allow little sufficient time for the contact with the tissue. A useful way to determine intraoperatively that as long as the original color of betadine persists, the antiseptic action persists, and when it gets decolorized with the tissue fluids, then probably that action goes away.
Yeah.
Then you suck it out.
There is a very good paper by Dr. Parvizi about this diluted betadine solution to put into after the implantation. He keeps it for a few minutes.
Yes.
And it has shown that it certainly helps to reduce the chances of PJI. So
after putting the betadine solution, again one has to wash with the normal saline so that
that's a very important point. Very important point that after that you need to really wash it with the normal saline solutions. Correct. Dr. Sharan Patil, this antibiotic sutures, any role?
No role from what I can see. There's no role. Yeah.
Okay. So of course there is no conclusive evidence to use these antibiotic sutures. Ultraviolet lights, they say that keeping these lights in the theater would certainly help to reduce the overall environment of the OT. Dr. Vaidya, you have this system in any of your OTs where you are working? Because you are going to...
Almost all of them in Hindujat, in Bridge Candy, in Reliance, but it should be used not during surgery. It should be in between surgery or overnight, wherever.
So excellent suggestion. I think the ultraviolet light, when the OTs are not functioning, you keep them on. It's one of the very good thing to reduce the environmental infection, as Dr. Vaidya said. Dressing, Dr. Rajesh Malhotra, occlusive or silver impregnated or a dry gauze. Do you think it will make any difference after the wound is closed, the staples are applied? Will dressing make any difference in the infection rate?
Yes, both occlusive as well as the silver impregnated dressing have been shown to reduce the incidence of SSI.
You recommend that this should be routinely done in our patients?
Yes, it has been shown to reduce the incidence of SSI.
Correct. Okay, so I think occlusive or silver impregnated dressings are there.
Only thing, silver sulfadiazine ointment which is available in our country, some patients might be allergic to sulfa. Only those patients one need to avoid silver sulfadiazine creams.
Okay. Fine. Okay. We asked a question about the cement in antibiotics. So I think we asked this question to Sachin about whether we routinely use the cement in the antibiotic or not. And the answer was that probably in the high risk patients, we use this. So what type of dose you recommend when you use the antibiotic? If you are not using the antibiotic loaded cement, or you are going to add the antibiotic powder into the cement, what would you recommend? What should be used and how?
Antibiotic, I routinely do not add antibiotics to the cement, but what is recommended is that if you want to add any antibiotic to the cement, it should be less than 2 grams per batch of cement that is used, and it should maintain the strength of the cement. Otherwise, it will alter the mechanical properties of the cement that you're using in a primary surgery.
Correct. So I think very important point you said that the amount of cement you add in the powder should be balanced, because you also need to see the mechanical strength of the cement, vice versa the antibiotic efficacy. So 2 gram in 40 gram packet is the ideal dose. Yes.
It is the 10% of the volume of the cement.
5%. No, 5%. It is
5%.
less than 5%. Volume by volume.
Volume wise, yeah.
When I say something, I think 10% is used when you are making the cement spacer, or when you are putting the the first stage. For the definitive implantation, it's the 5%.
5%.
10% is the upper limit beyond which it won't cure.
No, we're talking about primary, yes.
Yeah, so I think the dose is different for the cement spacer and for the primary care.
Absolutely.
Absolutely.
When you are using cement spacer, the maximum volume should be maybe it may go on to 20% volume by volume, because by that the cement becomes more porous and elutes antibiotic in higher concentration compared to if you put less of antibiotics.
Okay. I think I'm skipping the questions of the diagnosis because that has been very nicely covered by the Dr. Parvizi's lecture. So last few questions, we go straight on to the other subject. Indications and contraindications of using debridement, antibiotics, and implant retention with exchange of modular components for the management of PGI. Dr. Rajkumar, how soon or till how long you would recommend that we should do this debridement and change of modular implant and washout?
No,
there was some time limit?
Yeah, for a dire procedure, it is as soon as possible. Preferably within 4 weeks of time, a dire will be helpful. Anything more than 4 weeks, it is very, very risky procedure. It may not give the optimum result at all. So dire procedure, acute stage is the most useful one within 4 weeks of time.
In the knee, you always change the space, the insert?
Absolutely. You have to remove the spacer, insert, and then go wash, give a thorough wash, do the betadine wash, wait for some time in a knee extension, pull the joint apart, lavage everything, and put in a new insert. That is no doubt about it.
If I may just add that, just two things to remember. One is there could be infection behind the insert, between the acetabular cup and the insert, or the tibial base plate and insert. But more importantly is the polyethylene, which is the best surface for adhesion and biofilm formation for the bacteria. So don't leave the original poly inside.
So I was just going to come to that question to you, Dr. Rajesh. As you said, it is very simple for us to remove that insert of the knee, wash it out and put. What would you do for the knee, hip? Suppose it's a metal on poly. What would be the recommendation for the hip? What would you remove?
There are different techniques for removing the polyethylene insert or the ceramic insert. Most of the times we are able to get away without damaging it. For example, you can use a very thin K wire and put 2 K wires if there is any groove and any potential space between the insert and the cup. But then, if required, you may even have to sacrifice the poly, but I won't leave a poly inside, because the bacteria do get adherent to poly and they form a biofilm, and leaving the same poly inside is actually inviting trouble.
Yeah, I think my point was that even in the hip also you should try to do that. Is that correct?
Yes.
Yes, that's right.
Yes, absolutely correct.
Okay. Right.
One more. There are two important indications of dire. If it is a primary joint, during acute postoperative infection, within 3 months you can do. And number 2, when there is an acute hematogenous infection later, after the onset of symptoms, within 3 to 4 weeks one should do the dire. There are 2 indications of dire.
So Dr. Vaidya, how many times you think that you would try to do this type of debridement procedure, washout? You think that let me do one more time, it will probably subside the infection. So what is your threshold limit? You think that this procedure will work?
In only one case I have done 3 times. She was immunocompromised and diabetic.
Okay.
I think first attempt should be the best, and it should be really radical. It works. But one patient that I remember, I did it 3 times. And after 3rd attempt, she was all done well.
But the normal recommendation is that you only do it once and you do it best. That's what you are saying.
Yes.
Correct. Okay.
But one should not do when there is a presence of a sinus, when the implants are rouge, and the results are poor, when your CRP value is more than 60, and in inflammatory arthritis like rheumatoids. These are they give poor outcome in dire compared to other patients.
Yeah, we discussed this point little bit, but I asked Dr. Rajkumar that after dire, how long you think we should continue the antibiotics? Normal recommendations?
It has to be 6 weeks, 2 weeks of IV antibiotics and 4 weeks of oral antibiotics, depending upon the organism. And if it is a gram negative, then more of IV antibiotics is required. It all depends upon what coverage you are going to give, but preferably at least 4 to 6 weeks is a must.
Correct. I think this question of rifampicin was discussed by Dr. Parvizi, and they are saying that in a combination therapy with fluoroquinolone, it certainly works. So I just move forward. So what is the recommended duration of antibiotics?
I'll just add that is because
yes,
Yeah, I said that, you know, the reason why it is said is that if you give rifampicin alone, very quickly the resistance to rifampicin sets in.
Right. Um, Dr. Akos has already shown us, but in real practice, do you think that in India we have a role for a single stage revision in specific cases as he described, Dr. Vaidya? Have you been doing any single stage revision?
Single stage revision, never.
Okay. Any of the faculty members, they do the single stage revision?
I have done twice in patients who were like 85-year-old and 80-year-old, and there I knew the bug, but then I was quite apprehensive. We hardly ever get a position, a situation where you can get, you know, feel it suitable for that.
But you think your antibiotic regimes will be different in single stage, or it will be the same?
It would be the same, and the duration will also be the same. I don't agree with 10 to 14 days. I don't think that is a thing for us.
Correct. Okay. So I think that's the thing. We already discussed this culture negative therapy. Dr. Parvizi has already told us about this. And this was also discussed between the what metrics should be considered to determine the timings of reimplantation of two stage. I think Dr. Vaidya, you asked this question that how would you decide when to do the second stage now? When you have done the debridement and you are waiting 4 weeks, 6 weeks. So what are the parameters you would look into that now this is the time you should go and do the reimplantation? What would be your clinical practice advice?
I think there should be an antibiotic free period for at least 15 days. Aspirate the joint again, open the joint, and as you know, the medulla is open. Again, send 5 samples from both side medulla. Wait for your reports. If it is 5 to 10 in 400x in 5 fields, you have to do debridement again.
You mean frozen? You mean frozen?
This is not frozen. This is polymorphs per high power field, Mira's hypothesis.
What I'm asking, what you said that you do the
15 days of antibiotic free period. Aspirate the joint.
Yes.
Aspirate the joint and send it. Again, your 5 to 10 in 400x, confirm. If it is clear, go ahead, open, remove the spacers that you have put in, go in the medulla, take a pituitary ronger, go good 7-8 inches inside because bacteria are pocketed there right up in the medulla, if at all. Send a sample again, prepare your pathologies for what you are sending it for. So again, 5 to 10 in 400x, polymorphs are seen. I would abandon debride again. If it is not, go ahead and do proper reimplantation.
Okay, Dr.
I think we have got a slight, I've got a slightly different thing for the question. Clinically, the knee becomes calmer, better, and it shows a decreasing tendency of ESR and CRP, not necessarily completely coming back to normal. At about 4 to 6 weeks, I would go in and do the revision.
But would you aspirate all the time, second before the surgery?
No, not really. And in fact, I don't even do the antibiotic-free interval, and I don't aspirate.
Okay, Dr. Rajkumar?
Yeah, I don't aspirate before the surgery, but the thing is, it depends upon patient to patient. No fixed whether 4 weeks or 6 weeks or 8 weeks. Even sometimes you can even wait for 3 months. There is no harm in waiting for 3 months. But they say if the longer the period, the cement spacer might eat away the bone, the loose cement spacer. At some situations, you might need to, particularly in a tuberculosis or a atypical organism, where you need to wait for 3 months to 4 months. But provisionally, 6 weeks to 8 weeks is an ideal time for second stage revision.
I'll just add that we always aspirate.
Okay, Dr. Sachin, do you think that the ESR, CRP, they will come to normal? You should wait till then, or the downward trend itself is sufficient along with the D-dimer and other investigations?
So as you rightly demonstrated on the slide, downward trend is the most important, and it should stay downward. You should not have upward spikes going up again.
Correct. One more important point I would like to add, that after doing all these things, when you open up joint, inspection of the joint itself is extremely important. Intraoperatively, if there is any doubt, then one can send intraoperative frozen section and then decide about going ahead with the second stage or again putting a spacer.
Dr. Malhotra, do you send the intraoperative frozen sections?
No, I don't.
No,
I don't send it. but I do send the fluid for gram stain, but I don't send a histopathology.
Okay, Dr. Rajkumar, you want to add something?
Yeah, apart from that, there is one more situation called the unexpected periprosthetic joint infection. Even during the second stage revision, when we are doing, it is advisable to take multiple tissues in multiple places and again send it for culture. You can go ahead and do the definitive procedure, but wait for that culture. And if that culture again grows unexpectedly, some organism, you have to again treat it for appropriate antibiotics with the appropriate antibiotics.
Now this question, no, Dr. Vaidya, you need to ask this. I think all the faculty members, synovia sure, so not the brand, but the lateral flow technique for the alpha defensine we used to do. I was not aware that the synovial fluid which you aspirate need to undergo couple of procedures. But what we were doing, taking out the fluid, doing like a pregnancy test and seeing whether it's plus or minus. That's what we were doing. Now I realize today that that synovial fluid itself has to undergo some procedure, and what they are saying that the lateral flow test is not that reliable. So how frequently all of the faculty members, do we use this Ellis strip test in your routine practice? Because this is a very important guide to our all the colleagues and friends, those who are watching this. Please tell one by one. Vaidya.
Dipak, it's a very simple marker. And the way Parvizi showed, I think it's easy to procure. It's a colorimetric thing. Once you get it harsh pink color, this is infection. But only issue is your aspirate should not have blood. Correct. If your aspirate has blood, you're gone.
Rajkumar, quickly.
Yes, we don't routinely do that, but it is definitely a very good marker test for finding out if it is infection.
Between synovia sure and Ellis strip, what would you use?
Ellis strip.
Ellis strip.
Dr. Patil, Sharan?
Ellis strip.
Okay. Do you use that in your clinical practice?
Yeah,
Sinus sure is expensive, Dipak. It's very expensive, and I don't think it's practical.
Only thing about Ellis strips that there are 50 strips. You open and use one, then you cannot keep that bottle for using after 2 months or 3 months. The validity of this state goes.
That one thing has been the biggest deterrent for me to use this. We have some experience with the synovia sure, and we were very happy, but unfortunately it was withdrawn. For intraoperative assessment for second stage also, it was very useful.
Correct. But what is the cost of that whole bottle, Dr. Mohanty, about the Ellis strip? You said that you use one, but you might have to throw the other 50.
I have never used, but I know the disadvantage. That's why I don't.
360 rupees. 360 rupees.
360 rupees. Dr. Sachin, do you use this routinely?
I do not use this. I rely more on my cell count, which I do during aspiration.
Correct. Okay. So I think it's a good message. It's a simple test, easy thing, not very costly, as Dr. Vaidya said, and probably a lot of stress has been put by Dr. Parvizi in his lecture about this. We have already covered that. This is one question. Does the tantalum augments during the single stage revision influence the rate of subsequent infection? Do you think using a specific metal will help to reduce the infection rate, Dr. Vaidya?
I don't think so. I think it's like this, you have an infection and you are debridement and cleaning. I should focus on more. I don't think a fancy looking thing like this would ever augment or inflame the chance of infection. So it's an unrelated question. There is no evidence.
Dr. Navin, any questions from the audience we have, and how many people are still, or because we need to stop?
Still people are there, and some of the questions are there.
Please, you can ask few questions, because then probably we can.
What is the consensus on repeating the antibiotics intraoperatively? Any guideline on the amount of the blood loss in operative time?
Yes. Intraoperatively, if the blood loss is more than 2 liters, then one need to repeat an antibiotic. Number 2, if the operating time is more than 4 hours, if you have given, depending upon what antibiotic you have given. For cefazolin, it is 4 hours. For cefuroxime, it is 7 to 8 hours. And for vancomycin, it is 12 hours. So these are the half-life of the antibiotic. So what antibiotic you have given, depending upon if the operating time is more, then you need to repeat the antibiotic.
Other thing is, Dr. Navin, is the weight-related dose adjustment, because that is also important. A 40 kg weight and a 70 kg weight, the dose has to be different. That's very important thing, even the pre-operative shot when you give.
Okay. And as a trauma surgeon, we do a lot of antibiotic nailing. What is your protocol of mixing the antibiotic? When you mix with the powder and then you put a polymer liquid, or how you mix it?
First, you take the powder, then mix the antibiotic powder to the cement powder thoroughly. Then you gradually add the liquid and prepare the cement.
Okay. There are papers that in this method, there is a trapping of the antibiotic molecules and less leaching during the course of the time because of the early polymerization of the monomer and polymer. So what we do is, according to that paper, we wait for 30 seconds, mix the polymer and monomer, and after 30 seconds only, we pour gradually the antibiotic powder. Is it right?
Then there is a possibility of that you may not be able to mix the antibiotic uniformly.
It will mix, sir. 30 seconds only. You have to wait for 30 seconds. There are papers like this.
Okay.
In a trauma journals, there are papers.
Dr. Navin, it's almost 9.
Yeah, there is one question. Post-COVID. Post-COVID. Post-COVID, what is the role of filters and laminar flow in joint replacement?
Dr. Malhotra.
That's a tough question.
So I don't think that it is going to change much. In fact, in the COVID, the air exchanges are much more stringent.
Yes.
What you need in a COVID ward is more air changes than you need for joint replacement. And secondly, the whole concept is different because you need a negative pressure in COVID and as opposed to the positive pressure. So I think they are totally different philosophies. But the air exchanges which are required are much more actually, about 12 or so in an hour.
Right.
Yeah, in fact, we don't know where the laminar airflow itself might increase the chances of infection in the COVID situation.
Yes. I think the totally contrary negative pressure is the recommended thing at this moment of time. So only time will tell where we move on. Yeah.
Okay.
Okay.
Dr. Vaidya, last comment?
Yeah, last comment would be congratulating Gujarat Orthopedic Association.
Thank you,
sir. I think everybody has the same comment.
Rajesh and Sharan and Sachin, all old friends. Thank you for giving opportunity. Thank you for allowing us to interact with
my two colleagues, Dr. Yuvraj and Dr. Karthik.
Karthik and Yuvraj, I forgot taking your names.
They need an applause because they have prepared all the slides.
Awesome.
They need applause. Great.
Thanks, Sharan. Good to see you.
And thanks to all the faculty.
You will give me next time your helicopter ride. Okay.
Thanks to all faculty from Gujarat Orthopedic Association.
Navin, thank you so much.
Now I'm stopping the streaming, and then you can have a 1 or 2 minute chat. Relax chat.
We need to thank Cadila for
100%
getting this, helping us to spread this message. Also, Dr. Rajkumar for sending the message to Sri Lankan and Bangladesh Orthopedic Association. Cadila got the people from Nigeria and Kenya, and they have been supporting us with the products of Tenata Fort and Newplum, TH and Ketsium. And all the faculties, those who have put a lot of efforts. My Salim Javed was a Yuvraj because he prepared this whole script. The producer was doing So I don't know what role I am going to play, but you were all the heroes there.
Dipak, you worked very hard. You and Navin Bhai. Thank you so much for the opportunity.
Thank you very much for watching. I'm getting so many feedbacks on the WhatsApp itself. Thank you for watching this retelecast. And